Welcome to PerfWeb number 61, Vanderbilt University Faculty Forum number 3. And is everything okay over there?
Yeah.
We're it's like looks like it's going crazy on me. My okay. And there you go. And also the John Ingram Knowledge Nuggets. I can't remember which one it is. But with all of that said, no, seriously, guys, my computer, it's like the YouTube stream is not working right. Like it's blinking on and off. Do we have a good stream?
Yeah.
No, something's wrong. So you have a good stream?
Yeah.
Okay, well, I'll just keep going through it. I'll just power through it, I guess. Okay, so our sponsor, HET, we have hired 4 people. I want to believe that it's because of our great ad, but you can go to het.us and learn about us as a company. We practice in the Houston metropolitan area, and great career opportunity for everyone if you'd like to do that. Social media, please make sure that you like, follow, and share us on Facebook, LinkedIn, and Twitter, and make sure you give us the thumbs up and you share us and you click the bell notifications so that when we do programs, you're made aware of that. Subscribe, and I said that. Subscribing is probably the most important thing. We dominate in subscriptions, and we're really happy about it. It's really exciting. Our websites, perfusioneducation.com and perfweb.us. And a lot of people ask, why do you have 2 different websites? There is a reason for it. Perfweb.us is where our schedule is located, so you can see what events we have coming up, which reminds me, we have John Poland actually waiting and Dr. Hoffman for the Vanderbilt Faculty Forum. They're going to be talking about VADs, and I need to ask John, maybe if he's listening to me right now, he could be thinking about this. I need to make sure that I have approval for the next ones that we have coming up. So I might need to get you with Matt on that if you get the opportunity. You can reach out to us at contactus@perfusioneducation.com and send us an email if you want to join our faculty. You would like to do something very similar to what Vanderbilt's doing. We are very open to this. We want that collegial collaboration on an international scale, really. Our call-in number, if you'd like to be live on the air, you'll see that symbol pop up, 832-239-5358. If you have a question, a comment, would like to be but like to clarify something, whatever you'd like to do, you could be live on the air. We'd love to hear from you. Our MediWeb app, we've done some demonstrations of it, but look, it's a very comprehensive app, and there's actually 2 different apps. There's the critical care application for perfusionists and critical care nurses and physicians, and that has various different sections in it. There's a perfusion section with quick calcs, which you may find very useful. There's an ECMO section, hemodynamics, conversion, and there's an IV rate calculator. And if you go to that app and get it, all of that's incorporated in a $2.99 app. You also have a 99-cent app, which is only the IV rate calculator, which is great for nurses. Makes your job so much easier and can calculate a lot of things. But it's a really cool app. I suggest you check it out. It's very affordable, and I think that we continue to sell them. I say jokingly all the time, I just need to sell 1 million of them before I can retire. Our podcasts have become very popular. We're getting a lot of comments about our podcasts, but you can basically find the PerfWeb podcast anywhere that you like to stream your podcasts from. So please feel free to do that. I believe Dr. Hoffman is going to be here in about 10 minutes, but you can certainly bring John up if you'd like, and I can introduce our perfusion colleague for today, who is John Poland. And John, is he up? Can we bring him up? There you go. Hey, John, how are you, man?
How's it going? Morning.
I'm doing great. It's really good to talk to you. Listen, I've got your I've got your bio, and it looks like you graduated. Did you graduated from Vanderbilt, right?
From perfusion school, yes, sir.
Yes. How long have you been working there now?
This will be my second week.
Second week?
Yes, sir.
Holy mackerel, man! So how was the so tell us about that. So before that you worked as an anesthesia tech, and
Yes,
you
sir.
also did autotransfusion for a while, and so you
Correct.
have. How long did you do that for before you went to perfusion school?
10 years.
10 years. And then what made you
Yes,
decide to
sir.
go to perfusion school? Did they approach you or did you approach them?
Well, I've known all these guys here since I've been here, and one of them in particular, Phyllis, I've known her. She started in 2009, about the same time I did, and we've become pretty close friends. And about 5 or 6 years ago, she approached me about it and pushed me, and things weren't lined up at the time. They finally lined up in 2019, and I was able to apply.
Well, good for you. And you got in. Didn't just apply, but you actually
Yes,
got in.
it was the right decision. A little bit late, but I'm happy.
Excellent. Perfect. That is most excellent. I'm really glad. Um, but
Thank you.
hey, so John, tell. I'd like to hear more about your training. But Magic, do you have a second? Can you come here for a second, please, and see what I'm seeing? But what's mine doing this for? Do you think? Try a different browser. Okay, hold on a second, John. I've got to get my act together here. So we're waiting on Dr. Hoffman.
Yes, he's on his way in right now. He said he was running a little bit late. We had a long day yesterday.
Mm-hmm. So how many cases did you do through your training?
Because generally Vanderbilt University, they try to get us around 200 to 220.
That's a pretty good number.
Because of COVID, we got pulled out for around 2.5 months, and that was like right when we were really starting to rev up. And I think I ended up with around 160, depending on where you get. I think the top in our class was like right around 210.
Mm-hmm.
But COVID really, like I said, took me out for 75 plus days of work. And then I actually got COVID at one time, so it took me out another 2
Are you
weeks.
kidding me?
No, and then one of my roommates got COVID, which took me out another 2 weeks from clinic as well. So right when it started, they made us all quarantine and live together. So I ultimately missed around 3.5 months of clinical rotation time because of
Holy,
COVID.
holy mackerel! So now, I mean, what were your symptoms? I mean, were you really sick with COVID, or did you just have COVID positive?
No, the worst thing for me was congestion and
Uh
just
huh.
a back cough and a little bit of fever. But once that broke, it was just muscle congestion.
Wow, wow. So, question for you then: in your training with Vanderbilt and your program, did you were you doing the transports as well, the ECMO transports, or did you get trained on the heart in a box technology? Did like what all encompassed your training? What was that like there?
It was. It's really kind of depending on where we're at, and we're not here at Vanderbilt. I wish I was, since I kind of felt I was going to work here. It was kind of what you put into is what you're going to get out of it. No, that we weren't required to go on ECMO transports, but
Mm-hmm.
if I had one available, they would try to send me
Yeah, that's
to
fantastic.
one or four or five.
Mm-hmm.
Um, if I know it's going to be part of the job, I want to get experience at it and start doing it as early as possible. Because the more I have now, the farther it takes me early
Sure.
on.
So
As far as like Heart in the Box, again, we didn't get to travel with that. Usually it's kind of it's a packed airplane in those situations. So we only got to see it when it was actually back here at Vanderbilt, if we were
thanks.
available to see it.
Yeah, that's fantastic. That is really good. So did do you rotate with like how many cardiac surgeons are actually? Did you ever do cases with Dr. Petrasic?
No, I worked with him before, but not as far as a perfusion student. He was gone by the time we actually started in the program. But
You know,
I know of him, and I've known him since he was here.
You know, I used to work with him. I worked with him in Nashville when he was a fellow, and
Oh,
so he
really?
was, yes, he was a fellow when I knew him, and real interesting guy. He really went on and did some great stuff. I did cases for him over at St. Thomas.
Yeah, he's very well known.
Mm-hmm.
Depending on where I went on my rotations for school, certain people would ask about him. If this is where he was from, I would always acknowledge that he was. At Vanderbilt, I think there's 6 surgeons now.
Yeah.
Just at Vanderbilt. And depending on the school, we go on different rotations. We can go to like St. Luke's in Kansas City, University of Minnesota. So it just depends. We had like 13 locations we could choose from to kind of do our outside.
Uh-huh. How does that work? Do you have a hierarchy, or do you just pick where you want to go and that's where you go? I mean, I would imagine that if, you know, how do you manage more than one person wanting to go to the same place?
Well, we only had a certain amount of slots for certain places, so she would try to always get us one we selected. For me, I had a house in Nashville. I tried to stay pretty close, and depending on where people's skill levels were, or did they need more cases or something like that, they might have sent them to a more Vanderbilt-like university type situation. So it's kind of just, you got lucky. I ended up going to 2 places that I didn't even choose, which was fine. I liked both of them anyways, so it wasn't even an issue. But it was just logistics. COVID threw a lot of, everybody knows that COVID threw a curveball into everything. So that was, but I'm glad. I ended up going to Ballot Health up in the Tri-Cities, Kingsport, and then I went to Birmingham. So very happy.
Well, good. So, hey guys, I noticed that there's some jumpiness in theirs. Is that their internet access? It's their connection. Okay, good. Yeah, we'll just make sure that they speak up and speak slow. It's not that you're not closer. It's your internet connection.
Okay.
Nothing is ever perfect in this world, dude. We try so hard to have perfect. I think what Vanderbilt needs, I'm sure Magic will probably help run an AT&T fiber cable to the hospital, dedicated line just for you guys. Will make this a whole lot easier. So
that would be nice.
It would be. So John, tell us a little bit about what your passions are, what you focused on when you were in training besides just getting through that process, and what you really have an interest in as you move forward in your perfusion career that you want to be a part of.
Good morning, Dr. Hoffman.
We heard him. We always hear Dr. Hoffman before we see him.
The main thing as I came in was I knew a lot of the surgeons before. When Dr. Hoffman had just came in when I started school, so I didn't know him beforehand, but I knew Dr. Shaw. It was getting just comfortable with the surgeons and building trust with them through being there as much as possible. Showing, one thing is these guys got to trust us, and it's going to take a while for him to build complete trust in me. But the more I work with him, continue and be there, be seen, and just work hard. That's my thing. Is I'm not.
He's smart.
He's smart. So Dr. Hoffman, just so you know.
Except when I see that picture of a dog biting his arm, I'm wondering who would do that. He used to train dogs.
He used to train dogs. So what do you see in the morning? What does he bring?
He said the picture of me. There's some pictures of me from where I used to do police work, protection dog work. With the dogs biting me, he said he doesn't think I'm smart for doing that.
I understand. So
he keeps those hands twisting dogs.
Who trains who though? The dog or the trainer?
Well, with us, we train the dog, but depending on usually a lot of times it's the dog runs the owner. They say the dog's never the problem. Usually the owner's the problem.
Absolutely, I completely understand. So, Dr. Hoffman, very quickly, I think we introduced you the last time you were here, and thanks for joining us this morning. We're really looking forward to this presentation on VADs. But you're, just for the sake of the audience that may not have been here last time, you were born in New Orleans. And by the way, do you know a fellow by the name of Devinder Bhatia? He's also a heart surgeon, and him and his family are also from New Orleans. His wife, Gina.
Huh? I haven't come across him.
No, you haven't come across him. I need to get you two guys together because he's a super nice guy, and he's out here in Houston. I think you guys would have a lot in common. Anyway, so you also came out here to Texas. You went to Rice University in Houston. Of course, that's a big place. That's where President Kennedy gave his speech on us going to the moon some years ago, right there in the stadium. I've been there. Pretty interesting place. And then went on to Emory and to Grady in Atlanta. And your passions are really in stage heart failure, lung disease, pulmonary hypertension, mechanical support devices, and aortic surgery. And you've done a tremendous amount of work in heart failure physiology and patients going under LVAD, left ventricular assist device placement, and other novel therapies to extend the viability of donor hearts like the heart in the box, which you discussed already. So I think we have our slides, and I want to go ahead and get your program started, but I have a couple of questions for you before we do. One, it says Chapter 22, Devices for Cardiac Support and Replacement. So is that out of Hensley's CT anesthesia book, and that's Chapter 22?
Yeah, I wrote that chapter, so that's why I put that in there.
That makes a lot of sense. That's pretty impressive. I mean, you're a really young guy, and you wrote a chapter in this textbook. You know, I mean, unless you just have some way of looking younger than you actually are, yeah, it's really impressive that you've accomplished all you have, and you're just such an affable fellow. You know, I mean, you're just a nice person. So I really appreciate that. And I'm curious if you could maybe tell our audience about what John had sort of mentioned. You have to trust us, we have to trust you, and sort of that relationship that exists, which I don't think a lot of people who aren't in our industry really can appreciate, but that relationship of cardiac surgeon and perfusionists when you guys are managing patients, and what that relationship really means.
Yeah, it's a lot about it's a skill that you take from our different areas of life. It's not just us in the OR, but learning to trust someone is more implicit than it is explicit. And you know, I mean, one thing, this seems very, but in my mind, it's like a little test. If I'm about to connect the aortic and I say run up, and then I get with saline, I mean, that in my mind is the first thing. I'm like, okay, I got to look out for this person. Or if it comes up perfectly and it doesn't blast anyone, I'm like, okay, this person kind of knows what they're doing. And that's just one little snippet of trust. Mm-hmm. And then there's more of that of the case. And by the end of the case, you can kind of tell what you're dealing with. They can tell what they're dealing with. You know, for instance, if they suggest something and I think it's important to, you know, you listen to everyone in the room. You don't have to take everyone's opinion, but you know, I think a lot of people come up with reasonable opinions that I don't necessarily come up with my own or think about. So you know, trust goes both ways, and I have little things to determine if who I'm working with will do a good job, and then you guys have the same thing, and it goes both ways. And it's not really, hey, can I trust you? You know, that's pretty explicit. It's more of these little details, the devil's in the details, these little details that kind of add up and tell you if you are working with someone who knows what they're doing.
And that you know, you bring up such a good point. And that run up, you know, I have seen so many different ways of doing the same thing over my career. But what I try to teach people, and John, you can take this for what it's worth, is the last thing we need to do is stay in a position where we cannot actually see what they are doing in the surgical field. So you get up, you walk around on the opposite side of the pump, you use two hands, and you look and watch as you open that clamp and slowly bring that up. So other than being able to do that one maneuver, which I do excellently, I'm totally incompetent the rest of the day. But they think that I'm the best perfusionist that ever walked the face of the planet because I can do that. So for whatever it's worth. It
goes both ways, though, because if you watch anyone who's done cardiac surgery long enough, if they're standing on, I don't know which side of the bed you guys put your pump on, but on our side, it's on the patient's left in our ORs. The person on the patient's left should move out of the way so the perfusionist can see the pump coming up.
Yes.
And if you just have someone who I watch people who know what they're doing, and I watch them move out of the way so you can see. And then I watch some of the new fellows who just kind of stand there and block your view.
Yes.
That's a little piece of information that you guys get from us about whether you can trust us. Do we know what we're doing?
Yes.
And anyone who's done it, and these are just minor things. They don't mean a lot to anyone outside the OR, but for us, and for us, it's a big thing. And I think that I think it's funny when you get a new student up there, a perfusion student, and they don't know what they're doing, and they just blast you. And that's my opportunity to make fun of them and really get in their head. But if that's coming from someone who's been doing it for 20 years, you start wondering, are they getting dementia or something like that?
Well, I've been accused of that here recently. So I've been searching for my words a lot. So I've started taking Prevagen, which has really been helpful. I mean, so, whatever, that may be a good advertisement for Prevagen.
Right.
I seem to be getting a little better.
Can I interject something here?
Sure.
So I'm going to be working with this guy for a long time, hopefully, and it does not bother me. When you walk into the OR, you cannot have an ego. If he asks me something, I don't get upset about it, or if he questions me on something, I don't get upset about it, because ultimately, at the end of the day, it's his patient. It's all of our patients, but he's the front line, and he's the one that's dealt with the patient, the family, and I'm okay with him knowing exactly what's going on back there if I need to, because he's seeing everything going up there, and I might not be able to say everything, so I want him, if he is worried about me, something going on back there, not in a bad way, but just if everything's all right, I'm okay with him asking me that, that knows that I know that he's paying attention as well.
Well, yeah, that's a very good point. And of course you're pretty young in your career, John. So but you're not young, okay? It's not like this is your first job in medicine or in the operating room or whatever it may be. So a little bit different. But I consider everything that we do, whether it's Dr. Hoffman, whether it's you, whether it's me, whether it's anesthesia, or whether it's the nurses. Basically, we do performance art. We are always being watched, and we are judged by our last best decision, or our last worst decision, as the case may be. So, when I talk to people, I expect people to ask me questions or challenge me or watch how I do something or ask why I do it that way. Just like Dr. Hoffman or any other surgeon may be asked the same question. You're going to get asked in your career. So that's how we learn, number one. And number two, if you can't be asked questions and you can't feel under a microscope, you're in the wrong business, because we are performers. Every day we go to work, we are basically working for an audience. And ultimately the patient is the person that's most important in the room, and we're all caring for that person. But we, whether you're on TV, YouTube TV, like you are now, or you're in the operating room, we are performers at the end of the day. And one of my favorite sayings is, it's not enough to be good, you got to look good or no good. And you guys look really good today. So with that said, that's what's important. So with that said, Dr. Hoffman, we're going to get started straight away. I know you have a very long presentation today, which is going to be jam-packed full of really great pearls of wisdom and information that's going to be helpful for people. The title is LVADs, and you're starting it off with the chapter that you wrote in Hensley's CT anesthesia book, chapter 22. I recommend people out there get this book and read this chapter as a follow-up. So, Dr. Hoffman, the floor is yours.
Great, thanks so much. So yeah, like we talked about, this is a kind of an extended discussion of what we discussed last month. It's a little bit more geared towards the surgical and the anesthetic side of things, but I think it's important for anyone to know that, whether you're a perfusionist, a nurse, a surgeon, an anesthesiologist, an ICU nurse. Really, everyone should kind of have an idea as to what other people's roles are. So this is a little bit of an insight into the surgeon and anesthetic management of patients with LVADs. And it is based off a chapter I wrote in Hensley's CT Anesthesia, which is a book that I know the anesthesia residents and attendings read And I've seen even some of the perfusionists. Don't you guys have you guys base some of your lectures off of that?
Yeah, I've actually got this book.
Yeah, so this is, I guess this seems to be kind of an all-around book for kind of everyone involved in CT surgery. So let's go to the next slide. So if you get a chance, just take a look at chapter 22. This is a little bit based on that. And I know everyone here knows this, but we'll briefly talk about the history of LVAD. So it really starts with the history of cardiopulmonary bypass, because without that, and now some will argue you don't need bypass, but without bypass, you can't really put in an artificial mechanical pump. And we all know that bypass kind of got its roots in the 50s. The 60s saw an advent of temporary mechanical support. And the NHLBI in 1964, they came up with a number of, they were granting different programs, they were granting funds to come up with ideas for artificial heart, what they called the artificial heart program, but really, when you break it down, meant LVADs. And they were looking for someone to develop a pump that could provide full support, quote unquote, because I'll get to this in a minute. They wanted full support with up to 10 liters of flow per minute. Now, how you define 10 liters of flow, whether it's water or blood, it wasn't really clear. In my mind, an LVAD is really only partial support. I know people will refer to it as full support, but if you think about it, we've got a right and a left side of the heart, and you're only really supporting the left side of the heart. In fact, you're probably making the right side worse or unmasking some underlying RV dysfunction. So I think of an LVAD as partial support. Again, it's partial support. I really think a good, durable biventricular support option is a heart transplant, and to a lesser extent a total heart, but those have their own set of problems. And so 10 liters a minute, so you never see an LVAD get to 10 liters a minute. They're rated for it because, you know, that's tested with saline or some very non-viscous fluid. But really, when you're talking blood, you're getting 5-6 liters a minute. And really, do you need more than that? No. Can it get more than that? Probably a little bit. So Dr. DeBakey in '66 put the first pneumatic LVAD in. And in '69, Dr. Cooley put the first total artificial heart as a bridge to transplant. And these were terrible. I mean, they were great because they were the first ones done, but they were terrible in that the patients had complications and didn't live. But the first bridge to transplant in 1984 was done, the first LVAD as a bridge to transplant was done in '84. So we can go to the next slide. And so a lot of the older guys will talk about these old first-generation LVADs and how difficult they were. When we talk about first-generation LVADs, we're really referring to the X-Core, the PVAD, and the XVE. And some people would even say the Berlin heart can be thrown in there. I don't necessarily consider it. I mean, I guess the Berlin heart is an older device, but we still put it in, especially in kids today. So it's still in use. But these first generation models were really the X-Core, the PVAD, and the XVE. And these were, you know, as with everything in the 60s, there was some enthusiasm for LVADs, but that kind of went away and really came back in the 80s and 90s with these first generation devices. They were all pneumatically driven. They were pulsatile. They really couldn't be used as destination, what we call destination therapy, whatever that means now. And they were large, noisy, and had many infections, cannula malfunctions, and they were very difficult to explant. We use a lot of electrocautery in the OR, and especially with the PVAD, if you would cauterize anything, it would short it out and it would stop. It was not an easy pump to remove. And I'm not saying I'm an expert in taking these out because, you know, I'm not an old person, but I hope I don't offend anyone with that. But I know about these and I've learned about them and I've seen them. So these pumps are really, they don't exist anymore. They're just kind of probably in the Smithsonian. But then in the early 2000s and late 2000s, we started seeing these second generation pumps, which really was the HeartMate 2. It was FDA approved for a bridge in 2008 and as a destination in 2010. It's continuous flow, and it's a propeller surrounded by a metal case, which is termed an impeller. There are two devices. One is axial, which is the HeartMate 2, and one is centrifugal, which is the HVAD, the hardware HVAD. It's smaller, less noisy, less complications. Still hard to explant. The HeartMate 2 is very hard to explant. I keep thinking I'm gonna be taking out my last one, and they just keep popping up. And I've done a number of LVAD explants here that have been HeartMate 2s. I put a lot of HeartMate 2s in as a fellow some years back, but that really, we don't put those anymore. We do take them out though. And I'd say once every couple of months we get someone who shows up with a HeartMate 2, and I kick myself because I keep wishing that we're done with these, but we're actually not, because they're still walking through the door. And these are axial flow. The HVAD, the hardware HVAD, is not axial, it's centrifugal. So we can go to the next slide, and we'll get into the third generation devices, which are the HVAD kind of bridges the gap between the second and third generation, but the HeartMate 3 is really thought of as the third generation LVAD, which is, as everyone knows, probably 2016, 2017, and later, 2015. But the HeartMate 3 is what we put in a lot here. We put in some HVADs here as well, but the HeartMate 3 is really the third generation device we're using. The propeller is completely levitated magnetically, and that's what the company will sell. They think that it reduces pump thrombus, it's a bearing-less design, and it reduces friction, heat, and wear, and just the company will tell you it has better outcomes. The HVAD is partially magnetically levitated. Don't ask me what that means, because that doesn't make sense to me, but that's the selling point for it. Both of these are approved for bridge to transplant or destination. And I commented earlier that we're not sure what that means anymore, because at least here at Vanderbilt, we have a lot of patients we sign up as a destination LVAD. And then, sure enough, 6 months later, they've lost 30 pounds, they've stopped smoking, stopped using drugs, or whatever it is they were selected for LVAD for, and they come back up as a bridge and selected for transplant. So when we don't, I use bridge and destination, but we really have gotten away from using those terms in these patients. Really, in my mind, unless you're really under extreme circumstances, almost everyone is a bridge with an LVAD. And the question is, will they survive 6 more months on medical therapy so they can get their life in order, so they get a transplant, or do we think that they're not really going to get themselves together in 6 months, and you put an LVAD in them and give them time to settle out, which is not an easy discussion or decision to be made. These pumps are smaller, and so I say here that they can be used as durable bivads, but it's not a great option. The thing about bivads is you want the pumps to talk to each other, so that when RV flow is down, LV flows also go down, or if one is up, the other can go up. But if you're using two durable LVADs, like for instance 2 HeartMate 3s, and you're putting one on the right, one on the left, they're not talking to each other. So it's very complicated, the management of those pumps. And I guess if you say that there's any upside to the total artificial heart, it's that there's communication between the right and left side. But it's not a great pump either, but it's got its own set of problems. These third generation LVADs are small enough in that they can be implanted through other routes. So you can implant them through a thoracotomy. You can anastomose the outflow graft to the descending aorta, the ascending aorta, the axillary artery. I've seen the inflow. When I was a fellow, we did an inflow from the left atrium through the right atrium and then out the aorta. That was in a small kid, and we did that with an HVAD. So there are a lot of different configurations described for these third generation LVADs. And I think I get into this later. There are also other ways to use them. Let's go to the next slide and see what's there. So here are some pictures of all the devices I've just discussed. In the upper left, you've got the Thortec PVAD, the Berlin Heart, the Berlin Heart, which comes in an adult and pediatric version. We don't use it really in adults, but we do use it in kids. And the orientation is big with these, meaning inflow and outflow are directional. Thortec became Abbott. They make the PVAD, the XV, the HeartMate 2, and the HeartMate 3. Heartware is Medtronic, and they make the HVAD. All these companies have morphed in some way or another over the years, so it's very confusing when you're using these companies' names interchangeably. And then there's the Berlin heart, which is an external pulsatile heart, mostly in kids. So upper right-hand corner, the HeartMate 2 is this axial flow. You can see the blood comes from the LV apex and travels in line out to the aorta, whereas with a HeartMate 3 or centrifugal pump, it travels, gets propelled through this propeller, impeller, and out the outflow graft into the aorta. And bottom right-hand corner, difference between HeartMate 3, HeartMate 2, and an HVAD. So this is just for those who haven't seen a lot of these pumps, but I'm sure a lot of people here have. So let's go to the next slide. So why do we put an LVAD in someone? I mean, you could say, well, we should just transplant everyone, and that's kind of our theory here at Vanderbilt. You know, we think that the best biventricular support is a heart transplant, and so anyone we can transplant, we do. But we do have, and then there are patients that come to us and say, well, they're still smoking, they need 6 months of abstinence. Can they do 6 months of abstinence on medical therapy, or are they too far gone or too sick to just continue medical therapy? Do they need an LVAD just to get them to the point where they can be explanted and transplanted? So 10 to 20% of waitlisted patients will, without an LVAD, meaning they're getting hopefully optimal medical therapy, will die prior to heart transplant. If you take all comers, 30% of patients who are waitlisted will have an LVAD. Some patients are too old for transplant, so 70 is not really a cutoff. You've got to consider all their comorbidities and their functional status as a whole, but typically 70 is the general rule, like for if we should be considering transplant or LVAD on someone. And then, as I mentioned, some patients have contraindications, drug use, tobacco use, social concerns, whatnot. So this is why we put in LVADs. Again, I don't think that an LVAD is a be-all, end-all. I don't think it's the I don't think it's really cut out for, you know, I wouldn't want an LVAD my entire life. If it were to get me to a heart transplant, I'd say sure, but I don't think it's really full support like we say. Let's go to the next slide. So when we have our transplant listing meetings, we talk about this INTERMAX score or INTERMAX level. It's the Interagency Registry of Mechanical Assisted Circulatory Support. It's a database it was out of UAB. It's now owned by the Society for Thoracic Surgeons. And it basically classifies patients who are being considered for LVAD into groups, depending on how sick they are. And at the top is this INTERMAX 1 status, which means they're really not doing well, and the expected lifespan for someone who is in INTERMAX 1 without intervention is hours. And so these are the patients we're putting on ECMO or non-durable BiVADs. Really, we're trying to capture INTERMAX 2, INTERMAX 3, and INTERMAX 4 patients who are stable as outpatients or starting to slide, requiring higher inotropes, or being admitted with decompensated heart failure and requiring maybe a little extra support through inotropes or maybe even a balloon pump. And these patients, typically, when you put an LVAD in them, tend to do okay. The INTERMAX 1 patients really don't do well. They really do poorly. And so when you're choosing to put an LVAD in an INTERMAX 1 patient, you've got to choose wisely, because the cards are stacked against you just by the nature that they're requiring mechanical support. And if you start adding things to that, like obesity and drug use, then you wonder kind of where you're going with this. And maybe the better discussion is a palliative discussion, or can you support them on ECMO until they recover? Again, if for anyone who's training, I think if you're going to do an LVAD case, look through the patient's history, look through the patient's chart, and try and determine where they are in this which INTERMAX level they are, and that'll give you an idea of how difficult it's going to be to manage them afterwards.
Mm-hmm. How much?
Like I said, go ahead.
I'm sorry. How much of that is the acuity of their illness versus the more chronic and somewhat adaptive nature of those patients, in comparison?
Yeah, I think a lot of the patients in INTERMAX category 1, 2, and 3 are what I call acute on chronic, and I think it's both. And so you could have a chronic end-stage heart failure patient who is maintained on guideline-directed medical therapy and gets, I don't want to use coronavirus, but it gets an upper respiratory infection or a COPD exacerbation or some disease unrelated to heart failure, well, next thing you know, they're in decompensated heart failure requiring inotropes when they didn't before. So they're starting to slide, and it moves them up the Intermax. It moves them to like an Intermax 2, maybe. And so a lot of these Intermax 1, 2, and 3 are just patients who are chronic heart failure who have a second hit unrelated to their heart failure that then start to slide. Because in my mind, their heart failure is kind of in a perfect balance of being managed well with medical therapy, and then all of a sudden it's not. So it's both acute and chronic.
Mm-hmm. Thank you.
This, me looking at this is the first time I've seen this, and him talking about it. We try to look at patients' information, and this could give me might be before I even speak to him. He may not even be in the OR in the morning. I'm able to see this and kind of determine if we might need, in a situation where we might need a BiVAD in that situation, where he's talking about them sliding fast, we might have to go on RV support, depending on when we do this. So that's something that I'm going to actually go look at as well now.
Yeah, and I think that I think the decision for RVAD or RV support following, I'm going to get into this because it's a little bit of a complex issue, but yeah, that does raise the question, are they going to need biventricular support? So, and actually the decision for RV support in this particular presentation is in my mind, it's the most helpful and the most important thing that you can take away from this lecture. And again, I'll get into that in a few minutes. So let's go to the upper right hand corner of that last slide, if you could go back, I wrote here when I wrote this slide deck, Intermax 1, we don't usually go straight LVAD with them, so we'll put them on mechanical support and we let them settle out. It's really rare that you'll put someone on mechanical support like ECMO and then bring them to the OR for an LVAD. I mean, we make exceptions, but that's rare. So usually you got to get them on ECMO, and then you got to see what happens, because if their kidneys start to go south, their liver starts to go south, they're really not going to be a candidate for an LVAD. So, so Intermax 1 should, in everyone's mind, Intermax 1 without exception should probably be some sort of mechanical support with a decision about LVAD at a later time, but not concurrently. Anyway, next slide. So I thought this was really interesting. This is an article I found when putting this together. These are the trends in patients getting LVADs over the last 10 years. And I'll just read them on the left and on the right. The trends have been, we've been implanting a higher number of LVADs over the last 10 years. More of them have been going to African Americans. There's been an increase in the need for temporary mechanical circulatory support. Like I said, in the last slide, we've been implanting more Intermax profile 1 and 2 patients, although a lot of programs around the country have not policies, but have had internal discussions about whether, for instance, Vanderbilt, we don't like to, right off the bat, implant LVADs into patients with Intermax 1 scores. That being said, we've done it, and I've done it, but it's hard to justify, and the outcomes aren't as good. And so again, we put them on mechanical support and let them settle out. Here's that destination therapy creeping in again. These are patients who get LVADs and actually feel great and decide, I'm done. I've had patients come into clinic for heart failure, heart transplant workup, and they've got an LVAD, and they say, I just want to keep my LVAD, and I'm not really interested in another surgery, so they don't want heart transplant. And there's been an increase in the use of magnetically levitated technology, which is basically the HeartMate 3. But that's just a self-fulfilling prophecy, because that's really the only, there's the HVAD and there's the HeartMate 3. So we are seeing improved 1 and 2 year survivals. And I don't know if that's because our selection for these patients is better. We still see a lot of bleeding episodes and infection. It's really hard to keep clean, and that's a common source of infection. The incidence of stroke has gone down. The readmission rate remains high, and then withdrawal of care after LVAD is a rising cause of death. And I think that might be because putting an LVAD in someone allows their family to maybe have more time with them, and that's quality time. And when they realize, hey, this patient's not doing as well, but we've had our quality time, the LVAD has bought us some time, then they move towards more of a palliative approach. So Withdrawal of care does represent a rising cause of death, but that's not necessarily an accurate statement, because withdrawal of care isn't, I mean, yes, ultimately it causes their death, but they really die from multi-system organ failure or single organ failure. So next slide, please. So when I'm putting an LVAD in, I think about a lot of things. In our meeting, we meet every Tuesday and we discuss who's going to get LVAD, who's going to get a heart transplant. And we really lean hard on, the social workers and psychologists and psychiatrists to tell us about the patient's social history and whether there are any red flags, any direct contraindications for direct transplant, which would be active drug use, active tobacco use, weight, A1C or diabetes that's uncontrolled, financial issues. And it's unfortunate we're dealing with this, but there are some people who can't afford either a heart transplant or LVAD. You've got to be able to afford the medicines that you're going to be taking afterwards. Otherwise, you're going to have a pump thrombus if you can't afford the warfarin, or you're going to have rejection if you can't afford the immunosuppression meds. You wonder about compliance. I had a guy who came in and he told me he was non-compliant with warfarin in the past because he didn't like the medicine. And in my mind, if you can't be compliant with warfarin, then you can't get an LVAD. And then we talked about him. 6 months went by, and he took warfarin for 6 months straight. It was documented that his INRs were normal, or not normal, but therapeutic. And he came back up, and he was compliant with warfarin, and we said, okay, I think we can put an LVAD in him. So, lastly, this is not something I think. There are a lot of patients that come outside the city or who don't have running water, and you need power to run an LVAD. I mean, you just power, and it's not intuitive, but we've had patients who don't have power and have an LVAD, and they just have nowhere to plug it in, and they lose all battery power. So you have to have power. Because you have to keep things. Again, these aren't things, but if you're putting an LVAD in someone, you want to make sure that they're going to be successful. You don't want to set them up for failure. So what we'll do is we'll admit these patients 2 or 3 days in advance for a right heart cath, and we'll assess their volume status, their right atrial and PA pressures, and we'll as much as to really get their PA pressures down. And usually when their PA pressure is high, it might be group 2 pulmonary hypertension, which is pulmonary hypertension related to LV dysfunction. So that if you've got a high PA pressure, a mean greater than 20, and a pulmonary capillary wedge pressure that's through the roof, that's probably group 2, and they've got LV failure, that's probably group 2 pulmonary hypertension. And that, if all their filling pressures are high, that's a diuresis and get those down. If you've got someone with a normal wedge pressure but a high PA pressure, I'm getting off on a tangent here, but that should raise the possibility that you're not dealing with group 2 pulmonary hypertension, you're dealing with something else, and then you've got to work up their lungs and whatnot. But anyway, that's for another day. Come for a right heart cath, we'll status, and we'll diurese them. Usually patients have group 2 pulmonary hypertension, mild. And we'll look at echo on them, and what I'm evaluating is the RV. I want to see if it's dilated or decompressed. I want to see if it's dysfunctional or I'm looking at TR. If you have a normal RV, normal. If you've got massive, either it's a structural abnormality, which it might be, but it's rare, or it's functional TR, meaning your RV is dysfunctional, that you've got torrential tricuspid regurg. But usually if you've got torrential TR, you'll see a dysfunctional RV. But sometimes RV failure can be hidden by the fact that your LV is, and everyone focuses in on that. You don't really learn about the RV. So I'll look at the mitral valve, determine if they have mitral regurgitation. I'm not a huge fan of doing anything about mitral regurgitation at the time of LVAD surgery. That's cross-clamp time. There is some data out there that should be a little bit more difficult for patients with severe MR after LVAD's put in. And we'll get into that in a few minutes. AI is a big deal in patients getting LVAD. And we're going to go into this in a few minutes too. You can imagine if you put an LVAD in and the outflow goes to their ascending aorta and they've got a ton of AI, you're just going to create this loop. So that's got to be addressed at the time of surgery. And then I'll look at the pulmonary artery pressures and the pulmonary vascular resistance. You want the PVR low, you want the PA pressures low, and usually that comes with diuresis. And you want to make sure the PVR is reversible with nipride. For instance, if you get a right heart cath, you want to make sure if the PVR is high, will it reverse with nipride, indicating that you're just kind of total volume overloaded and your pulmonary vascular resistance is in fact not super through the roof. Anyway, let's go to the next slide. All that is going to come couple slides. So what is RV failure after an LVAD? So we know that 30% of these patients who get an LVAD will develop RV failure. And part of me thinks that the RV was always dysfunctional in the beginning. You're just unmasking how bad it is because now you've made your LV normal by putting an LVAD in, you've offloaded it, and you're returning all this blood to the right side. So you're unmasking all this RV failure that wasn't there before. We say 30%, it could be 40 or even 50%. A lot of people do have RV failure after LVAD. In the etiology right now, there are a couple things we think cause RV failure. And here are the top three. I think I put three in there that I think are really plausible. Changes in right coronary artery blood flow, which lead to a negative feedback loop. So the right coronary on it really continues just based on your RV compliance works. Infundibulum is very compliant and allows blood to move through circulation continuously, but it's dependent on intact infundibulum. And so, for instance, you put an LVAD in, a left ventricular assist device, you drop the left ventricular end diastolic pressure. And you end up shunting blood to the left main coronary artery because now the left ventricular end diastolic pressure is so low that blood flows more easily through the left system. But there really isn't a corresponding drop in RV pressure. In fact, RV pressure probably goes up a bit after LVAD. And so you probably lose a bit of the blood flow through the right coronary system. I call it a shunt. It's not a shunt. It really is not a shunt. I just call it that because that's how I picture it. It's really a preferential flow to the left side. Another thought about RV failure is you lose this intact pericardium. And when you look at how the RV and the LV, what the interplay is like between them, there's a septum that the septum accounts for about 2/3 of the right ventricle. And you get ventricular interdependence, which means that the septum causes the right ventricle and left ventricle to rely on each other for adequate contraction. But the third part of that puzzle is the pericardium, because with an open pericardium, you have this almost unlimited part to expand, but not actually contract. When your pericardium is intact, it really constrains how much blood can be in the heart before it needs to contract. And I'm not saying that the pericardium has muscle in it or that it has the ability to contract, but it's like it's like a really tight-fitting piece of clothing. You can't really continue to eat. You're going to feel that pain a little bit sooner in a tight-fitting piece of clothing than you are if you're wearing baggy clothes. So I think an intact pericardium is very essential for RV contraction, not for the contraction itself, but for the ability to maintain that contraction. You have loss of septal contraction, which I talked about, given how much of the septum plays into RV contraction. And then you have loss of contractile reserve, which is what happens when you have this huge volume shift of blood that's kind of been sitting on the left side is now being pumped out through this LVAD. And all this increased blood flow is being returned to the right side. So, for instance, you got an output of maybe 2-3 liters a minute before your LVAD. Well, your right side is going to be used to accommodating a blood flow of 2 to 3 minutes coming back, because what goes in comes out. Now you put an LVAD and you ramp it up to 6 liters a minute, you're going to way overload that right side, especially if your volume overloaded, which is why admitting them pre-op for right heart cath and diuresis is so important. And so if you think about the Starling curve, and I know this is going back to physiology, and I keep saying I'll get into more of this later in the lecture, but this lecture just keeps going on and on. You might need to stop me, but you'll fall off the Starling curve because your RV muscle will stretch and stretch and stretch, and suddenly the muscles will not overlap anymore, or will overlap, but will not have the same ability to contract down. So I call it falling off the Starling curve. You call it whatever you want. That's what it is. That's what it was described years ago. So how do we treat RV failure? There's pacing, inotropes, pulmonary vasodilators, and RVAD, and ECMO. And again, I'll go through these in a few minutes. So let's go to the next slide. So when I'm thinking about putting an LVAD in someone in the OR, I really, these need to be, I guess they don't need to be, but they should be quick pump runs. I mean, less than an hour ideally. Unless you're, sometimes you got to do some other things. You really don't want to cross clamp. I don't cross clamp for any of these. Again, I think it's a morbidity in patients with heart failure. You got to decide how you're going to cannulate. If I'm doing an LVAD through a sternotomy, I'll cannulate centrally. If I'm doing it through a thoracotomy approach, I'll cannulate femorally. And it really, you got to decide what approach you're going to take beforehand. I mean, you could go central and cannulate femorally, but I don't really see the point in that. I don't really put a cross clamp on if I'm doing an AVR at the same time. I will put a cross clamp to fix it, and whether I'm doing an AVR or a park stitch, you know, your clamp time can vary. Some people do off-pump LVADs. I've not done one. I'm not so sure I would do one. I don't know how you would do one. I don't know that it's safe, although it's been described. I know we used to do them here. I almost always put a femoral arterial line in because that can be converted to a balloon pump or ECMO if necessary. And then I like to come off on inotropes and pulmonary vasodilators. I have this secret combo that I've kind of picked up over a couple of years of practicing where I'll do routinely epi-dobutamine and Flolan. And I know epi-dobutamine combo is a little bit, anyone who understands cardiac physiology be scratching your head and wondering why you use those two. That's just what works for me. And I think a lot of what we do in medicine is just what works for the person. It's not, there's not a lot of data behind a lot of what we do. And so I just choose epi-dobutamine, but I'm okay with epi-milrinone or dopamine or just epi alone. And you got to think about, actually, when I'm considering what I'm going to do, our cardiologists here and our ICU attendings here are very comfortable with epi-dobutamine and Flolan. And if you suddenly decide, well, it doesn't make any sense, I'm going to change to some other combination, and you come out on milrinone and dopamine and inhaled nitro, they're going to be scratching their head, and the minute they get up to the ICU, they're going to be switched back to epi-dobutamine and Flolan. At least here, where you practice, it could be another thing. But you know, whether you agree or disagree with a policy for coming off bypass, you got to think of the people you work with, the institution. So at our institution, it's epi-dobutamine Flolan, and so that's good time. And the best way to have good outcomes is to do it the same way every time. So again, just if you're that program or that program that's new, just the ICU uses and how they and what the standard protocol is, and then use that coming out of the OR. It's very easy to do that rather than to do what you come up to the ICU and totally switch out all the lines and drips for something else. So whether or not there's data for it, if it's instituted, then do it. If you think that it's wrong, then that's a discussion. You should stay in line with what it does so that everyone is comfortable. Anyway, go to the next slide. So when I am in the OR, I'm looking for a couple things. I'm looking for low PA pressures. I'm looking for a map that is 60 or 70. When I took this picture, I don't know, you must have been doing my perfusion because the map was a little low. But I'm looking for no pulsatility because that's important when I cord the LV. I don't want a lot of pulsatility. I don't want to be ejecting air. So I'm looking at a flat arterial tracing, maps of 60 to 70. 50 is okay, but a lot of these people have chronic kidney disease, so I like to run them a little higher. And maps of 60 with vasopressors is a little bit of a lie. Maps of 60s with more flow would be my preference, but whatever you can do to get there. And then a PA pressure that is also non-pulsatile and also, single digits or teens would be fine. So let's go to the next slide. So this is a quick discussion of this. So I'm not an anesthesiologist, I can read TEs and kind of get an idea of what's going on, but I don't do a lot of them. So I'd like to talk about this. I do need to take a 2-minute break. I'm getting calls about a procurement I've got to do in a couple hours. Can I take a 2-minute break? Can you guys talk for a second?
Of course, please, go right ahead.
I'm just going to step out for 1 second.
No problem. So John, when he does these cases to get those numbers, and I really appreciated what he said about liking to increase flow versus pressing them to get that mean arterial pressure the way he wants it to be. Of course, sometimes you'll overflow your cannula, but and a heart will start getting stuffed. So there is some balance there. But what do you usually do? Like, how do you manage that situation?
Well, and just like you said, we will, if we're trying to keep pressure up, I try to give as few drugs as possible. You know, I mean, just like everybody else. So I'll try to increase flows if I need to. If I do need some support, if I am given some neo or anything like that, and I'm continuously having to give it, I'll ask anesthesia for a little bit of support. So we're not sitting there just dumping them into the pump. Let them. You know, the good thing about here is I can communicate with anesthesia, and they will, you know, they'll start a drip or something if I need to.
Sure.
It's really just depending. I'm going to flow what I can, and it's talking to him as well. It's just finding out, you know, are you filling up? Is there any issues up there? You know, he's good about letting us know as well as if we're filling up on that right side or anything like that.
Sure.
So it's flow is always a good thing. You know,
what's your preferred presser? Is it neo or is it norepi?
Neo.
Neo, you prefer
if anesthesia starts something, normally they'll start a norepi drip if we need a little help. But on pump, we almost always give neo.
And do you do your perfusion cases, your pump cases, all with just continuous flow? Do you use pulsatile flow?
No, continuous flow.
Continuous flow.
Sir.
And then if I could ask, you know, what do you, like on these cases, do you have any CO2 issues? Do you keep your CO2? I'm assuming they're flooding the field with CO2 if they're going to be coring out the ventricle.
Yeah, we're just watching that closely. Since we're normothermic, we don't cool down any on these guys. I may, you know, cool down to 30, 35 or something like that at max. But we usually stay normothermic with these guys, so we try to keep them normalized. If we know they're using CO2, it's just to see around where they core the apex and everything like that. I'll monitor that closer, but that's just a combination of knowing how much my pump suckers are tucked up, you know, make sure that I'm not taking back all this CO2 from the field. So, no, again, it's usually I run, you know, around normal, between 40 and 45 on my CO2 on all these.
That sounds good. Okay, very good. Doc, you got your procurement?
Yeah, we're working on a couple things, so.
That sounds great. Okay, if you need a break, just let us know. No problem at all. John and I had a good conversation, so we'll throw your slides back up and keep moving forward with your coring techniques.
Perfect. Awesome. So again, I'm not a TEE. I'm not an echocardiographer, but I've been doing this long enough that I can kind of get an idea of what I'm looking for with different TEE views. And so this lecture was for anesthesiologists who do TEE and probably know a lot more about this than I do. But I'll go through each individual view and what is helpful for me. So the mid-esophageal floor chamber will give you an idea of what the right and left atrium look like. Excuse me, and what the our right and left ventricle look like. And it's a kind of an overall all-functioning view. I use it for weaning bypass, titrating LVAD RPMs, and watching the septum, and to identify any problems with unloading of the heart. There are three other mid-esophageal views. There's the long axis, the two-chamber, and the mitral commissural view, which I'll give you a kind of a look at the LV apex. And the LV apex in everyone is a little bit different. There's this dimple that I discussed last time we did this. We talked. There's a dimple where the true apex is, but that doesn't always correspond to, especially in these dilated patients, doesn't always correspond to the apical area where you're going to want the inflow cannula aiming at the mitral valve. So I use these mid-esophageal views, two-chamber views, to identify the true where we should put our LVAD pump. If I want to see the RV free wall, I'll go to the mid-esophageal aortic valve short axis view, which is this one in the upper kind of to the right. If I'm looking for air in the root, I'll want to go to a mid-esophageal aortic valve long axis view, which I used to look at a lot when I was de-airing and coming off pump, but there's always just so much air, I stopped looking because it doesn't really help me anymore. So it just is what it is. If I'm cannulating from the groin with like a 25 French venous cannula and a wire, there's this mid-esophageal bicaval view I'll look at, which will give us an idea of the SVC, IVC, and the right atrium. And then if I want to identify how well I'm unloading the left ventricle, it's usually a transgastric view, and it's a short axis view of the LV, and sometimes a little bit of the RV, but can give you an idea of how well the LV is decompressed. And so these, for me, and I can independently interpret these without any sort of help. I know exactly what I'm looking for. Now, I can't twist the dials and get there, but I can, once I'm there, I can identify what I need to know. And so often at the end of the case, or as I'm coming off the pump, I'm asking the anesthesiologist and the residents to toggle between multiple views, because you can't just put one view up and then forget it. You got to go from view to view. You've got to, and often when I'm coming off pump, so when I start, I'm going to this bicable view for cannulation, and then I'm looking at the mid-esophageal forechamber just for an overall idea. When I'm identifying the apex, I have these 3 views on the left, 3 mid-esophageal views. And when I'm coming off pump, I'm really looking at 2 views mostly. I'm going back and forth between the mid-esophageal forechamber and the transgastric short axis views, and I just toggle between those 2.
Now,
was there a question?
Yeah, well, just for clarification, so, you know, and because I think this is an important concept for people, you obviously are flooding your field with CO2, and so when you do see bubbles, if you will, or gas in your route, it theoretically is going to be CO2, or should be CO2, or a large portion of a CO2, much more dissolvable and less likely to cause problems later on for any neurologic or other end organ deficit.
It should be CO2, but again, you don't know, because when you, and I found when you core the LV apex, there's a huge pocket of air. And assuming you're not ejecting, the air is just going to sit in the LV apex, because you've got to see what you're doing. So I put a pump sucker in, I'm cutting out muscle, I'm cutting out thrombus, and then I take the LVAD pump, and it's got a little, I don't know if they do this everywhere, but there's usually a little glove on the end where the thing's been de-aired. And I take the glove off, and I turn it over. And so all this air now goes into the LVAD pump.
Right.
Even if you go quickly and put it right into the LV apex. So now there's air in the LV apex and air in the LVAD pump. So no amount of CO2 flooding the field is really going to fix that. So while I like to think it's a CO2, I think it's probably, there is a lot of air. And I think if you talk to a lot of older surgeons and anesthesiologists who either never used CO2, a lot of them either never used it or don't believe it as a way to de-air. So, but I use it just because I don't get upset if the CO2 is not set up. And at the end of the case, I mean, again, like I said, I know it's hard because you're always going to see air in the root. So I've almost stopped looking because it's not going to change anything I do. I de-air the same way every time, and patients do well. So
well, you know the perfusion mantra, I'm assuming.
What's that?
No bubbles, no troubles, but what's the little air among friends?
That seems more relevant on the venous side of the ECMO circuit, but sure.
Oh, we just accept things. Sometimes you just have to accept things. Okay, sir,
Sometimes
please.
you just got to go with it. Anyway, let's go to the next slide. So this is a video I created. I don't know if there's someone who can press play, and this thing moves fairly quickly, but I'll try. So this is a reduced sternotomy LVAD I did. So this is the start where you're just getting into the sternum, using the saw here to get through the sternal bone. Again, redos are a little different than most. You've got to take down all the adhesions, and I get the sternal retractor in there early. One can be quite wet, so I use blue towels. So the first thing I do is identify the aorta, which is what I'm doing here. And once I've got the aorta identified, I carve out the right side and try and get near the right atrium. And this is aortic cannulation here. And all this goes real quickly. So here's the part about a little air amongst friends. And I think you're going to see the assistant on the left side not move when we're trying to come up. See, look, he's just standing there like a buffoon. I don't know who that was.
That was pretty good. That was actually pretty good.
So here we are. Here's the right atrial cannulation. I use the scissors to spread the right atrium, and then I put my cannula in there. And now we're cannulating the aorta. And so here's me identifying the LV apex with one of those short axis views. And what I'll do is I'll sew a running proline around the LV apex onto the sewing ring. And this is how I core it out here. So I should have let these run for longer.
So you want that LV full?
Yes. I don't actually. Yes, it's nice to have it full, and maybe people are doing that behind my back, but I don't ask for them to fill the heart. But here, I took that piece of myocardium out, and I'm doing a running proline suture to get this LV apex in place. There are some nuances here. Here's the pump in place, and now I'm tunneling the drive line. There's some nuances in that I core before I sew the sewing ring on, but that's more of a surgical nuance than anything else. Sometimes this coring can be difficult if someone's had, upper abdominal surgery or redo surgery like this. But I make a counter incision and I pull this thing out. I really like to tunnel this thing widely because I think that the more you tunnel, the less likely you are to get infection into the pump. But I don't know if that's true. There's nothing that's ever proven that. But you'll see I do this. This is a counter incision. I don't just go straight out to my final destination. So, and you can see in the bottom, the outflow graft is just sitting there clamped. So right now, the LVAD is in place, the outflow graft is clamped, I'm tunneling the drive line. And it looks barbaric, and it is, but, so here I'm making an aortotomy to anastomose the LVAD outflow graft onto the aorta, and I don't have a video of the final product, but that's about it. And that's the kind of the big overview of how an LVAD goes in. And so we can go to the slide there, unless there are questions. We always go that fast. That was a pump time of about 2 minutes.
Yep. No, I think that, I think it's very remarkable. That's one of the big, I really, I think as far as the technique, I mean, I would think coring the ventricle, you wouldn't want it to be completely collapsed. I would think that'd make your job a lot harder. But there's probably, when you pick the heart up like that, you probably generate a little bit of AI, and it probably fills it up naturally just from you really don't have to restrict any flow. It's just going to happen, I would imagine. But your drive lines, I mean, that is a huge problem, drive line infection, because the tissue is going to naturally want to ingrowth into that. So, that there's a lot, I think there's a lot of work being done in reducing that, but I don't think we're there yet.
No, I think what will help will be a total implantable heart LVAD that has an external battery.
Yes.
Like, how we recharge our iPhones on the pad.
Yes.
I think that'll help. But going back to your point about AI when you lift the heart, so the upside of a sternotomy is that you can see everything you need to do, but you've got to lift the heart. And so that's why when I have the heart lifted but not yet cored, I'm keeping a close eye on those PA pressures, because that'll tell me how much flow I have in the LV and back into the pulmonary circulation. And I don't know, we went over it very quickly in that video. I took a picture of the flows, and the PA line was flat and low, and there was no pulsatility in the LV. So once I pick the heart up to identify the apex, I identify the apex and I core it almost right away, because now I'm completely decompressed again, even if there is blood in the heart. And I get concerned that I've got a lot of blood flow from the aortic valve. I've got more AI than is being sold to me on pre-op TE or workup. The benefit of a thoracotomy approach is that the LV apex is sitting right in your face. There's no lifting that needs to be done. You just core right where you are. And therefore, you minimize the LV distension, which I don't care so much about LV distension in these patients, but the subsequent rise in pulmonary artery pressures, that's more what I care about. So,
have you ever seen in those circumstances where, as you said, your AI maybe was undersold, and you ended up with a flash pulmonary edema or anything like that?
No, I mean, not a flash pulmonary edema, but I see situations where I look at someone has quote unquote mild AI on echo, but you look at the echo and you see the jet's a little eccentric, and you say, well, I'm not sure that's mild. It might be on the upper end of mild. So I get to the OR and I tell the anesthesiologist, take a look at the AI, tell me if it's mild, and they look at it. I'm thinking of one case in particular a couple of weeks ago. Well, they say, okay, it's mild, but it's on the upper end of mild. And so sure enough, I raise the heart and I core, and just blood is everywhere in our face.
Yeah.
And that tells me I just need to replace the aortic valve.
Yeah.
And so, and it's not so much flash pulmonary edema. It's more, do we need to replace the aortic valve or not?
Okay. Yeah, I see what you're saying. So you don't. So really, your issue, you're looking at those well, if you didn't core right away and you filled
Right.
it, you blew the heart up, that could have its own problems.
Then you could have a problem.
But really,
Right.
it's your ability to complete the surgery, because if you can't see, you can't do it. Just
Right.
out of curiosity, are these? I'm assuming these LVADs are total flow. Is there any? Is there ever an opportunity or ever a time when you would consider just obstructing the left ventricular outflow tract completely, completely closing the aortic valve outlet, and you would still have coronary flow because of your outflow VAD? But has that ever happened? Is that something that could happen?
Yeah, you can do that. You can do that, although it's not as easy as it sounds. I can. It's almost like I'm looking through these magnifying glasses with one eye shut, and I'm seeing a very narrow portion of the LV apex and left ventricle, and I can see the mitral valve, but not all of it. And so identifying that area is very difficult. And so once the heart is cored, well, then you're decompressed. I mean, you should be decompressed. And if you've got a lot of blood flow, just put another pump sucker, and eventually, there's no amount of blood that you can't control with a bunch of pump suckers.
Mm-hmm.
So, if someone's got bad enough AI, like let's say they've got severe AI, then I might replace their aortic valve before I even do the coring and whatnot.
Mm-hmm.
So it just kind of depends on how things look.
That makes sense.
Yeah, you've just got to have that plan ready beforehand. So what do we do with mild or more? I mean, mild AI, sometimes you can leave alone, but if it's on the upper end of mild or moderate or severe, you got to figure out what you're going to do with it. I went through a period of time where I did a lot of park stitches, but I've seen a couple of them fail, and when they fail bad. I mean, the patients just kind of die right away. They get bad pulmonary edema, their flows go way down, and so I've gone away from the park stitch and gone towards replacing the aortic valve in everyone. And the nice thing about an aortic valve in someone who's getting an LVAD, like you can put a 19 millimeter valve in and not worry about it because they've got an LVAD. So it's not a huge deal. Other things you can do, so the park stitch, which is a central stitch, you can oversew the valve completely, which you can imagine if the LVAD stops, then you got problems. You can take a pericardial membrane and oversew the aortic valve as kind of like a plate. But I think the best course of action is just replace the valve if you're going to be in there working. So, and if you're interested, you can check out this article by Park in JTCVS in 2004, which describes the park stitch and the outcomes associated with it. And granted, the outcomes are pretty good, and it doesn't add pump time or anything or cross clamp time. But again, I wouldn't cross clamp unless I had to fix the aortic valve. So I don't think adding an aortic valve adds a lot more cross clamp time than a park stitch.
And you'll have to forgive me. I don't mean to keep asking you questions, but I keep getting these thoughts in my head, and I'm curious. Are you going to use if you are going to replace the aortic valve, let's say you have severe AI and you have to replace the valve or you have to obstruct the LV outflow, are you going to preferentially use a mechanical valve versus a tissue valve, or tissue valve versus mechanical, and why would you choose one versus the other?
Yeah, the intuition is that you're going to have to be on Coumadin with an LVAD. So why not just use a mechanical valve? But those patients tend to do not so great. They tend to do poorly, valves thrombose and whatnot. So I just put a tissue valve in them. And, let's say they're alive in 10, 15 years and their valve is tight. Really, if they've got an LVAD, I don't care as much if their aortic valve gets stenotic. And, I wonder, although this has never been proven, but if you've got someone with a tissue valve who you lose therapeutic Coumadin the rest of their life, I wonder if that is going to delay valve stenosis, prosthetic valve stenosis.
Mm-hmm. Yeah, so
I put a tissue valve in.
Yeah, I guess my thought would be, it's not going to be moving like it normally would, it's always going to have that closed tension on it. Of course, if you had tissue, if you had degeneration and you just developed AI, that would be one problem. But I don't know. It makes.
But in patients with tissue valves who develop AI, they have a stent, an external stent that you can then use for a TAVR. But it's very difficult to TAVR someone with AI who has a native valve. It's very difficult, and you can't TAVR someone with a mechanical valve. So I think if you're thinking in terms of long-term care, a tissue valve gives us the most options down the line. For instance, if they develop AI, they get it a TAVR. If they develop AS, who cares? With a mechanical valve, if they develop anything, you can't really do anything about that. You're kind of stuck. So I think the preference is a tissue valve.
Okay, yeah, all of that actually, when you think that out all the way, that makes a lot of sense to me.
Yeah. We can go to the next slide. So there are a lot of groups around that'll fix all these other valves and problems. I'm not a fan of doing a lot. I think I'm of the school that less is more. So if someone's got severe MR, which a lot of these people do, I think unloading the LV a little bit will make the MR better. So I won't do anything. I just leave them with severe MR. And it may complicate postoperative care, but it doesn't usually. I've not found it to. TR, I don't do anything. It's just a marker for RV failure. So I keep an eye on the degree of TR after the case. If you injure a graft while you're doing a CABG, you may want to, while you're doing an LVAD, you may consider fixing that, or you may consider bypassing that because, for instance, if you got someone who's living off a saphenous vein to the right coronary and you get into that while you're doing your LVAD, they're really going to struggle with RV failure after. To some extent, we do oversew the LAD, the distal LAD, with every LVAD we do, just putting that sewing ring in. So, but that doesn't mean there's an indication for CABG. So I'll do a CABG if I injure a vein or a lemma LAD, but not routinely. And then, because if they've got coronary disease and you've committed them to an LVAD, you've already committed them to moving down the pathway of heart failure. So next is a transplant, or they're going to do fine with their LVAD. I don't usually do a maze. Sometimes I'll ablate ventricular tissue. Sometimes if there's like scar tissue in the LV and they've had like really bad VT, I'll cryoablate that. It does add extra time to the case. And it's sometimes hard to identify this scar tissue. And just by coring the LV apex, you're getting rid of a lot of the scar tissue that might be a nidus for the VT. And then left atrial clips or ligations, sometimes I've done it. I'm not sure what the benefit is, especially if they're anticoagulated. But I've also explanted hearts that have had these big LV, these big left atrial appendage clips on them. And, I've done it, and it's hard. It's very hard. And I've torn the pulmonary artery trying to get one of these things out because it's got all this felt on it. So it really adheres to everything around it. So if there's no need for it, or if there's no, I try and stay away from doing anything with left atrial appendage. So next slide. So how do I come off bypass? Well, I go real slow. I try and go slow. I get a little impatient sometimes, but the goal is to get off bypass. The goal is not to get to max LVAD flows very quickly. The goal is to just get off bypass. And if you've got someone with heart failure and an EF of 5%, if they were able to go on bypass, they're going to be able to come off. And you need to decide beforehand the risk of RV failure, and then you need to your pulmonary bypass accordingly. So if the risk of RV failure is high, I'll come off with RPMs, and this is for heart rate 3. I'll come off bypass with RPMs of about 3,000 to 3,500, and I up-titrate that slowly after bleeding controlled, the chest is closed, and while we're in the ICU over multiple hours. If there's really low risk of RV failure, the RV looks good, I'll kind of fly off bypass and ramp it up to 5,000 and see what we get away with. But the argument for moving quickly to goal is, let me back up. I think that if the RV will tolerate it, I'll ramp it up quickly. And when I say I ramp it up, I do it safely, and it's a little bit of a test for RV function. I want to ramp up to 5,000, which is where I like to end up on these LVADs, and see what the RV can tolerate. And if the RV can't tolerate that, it tells me a lot about their underlying RV failure. But the argument for moving that quickly is to stay away from flows that are very need to kind of move along. But whether that means you need to move along in the OR or you can kind of move them up after they get back to the ICU is debatable. So with the HeartMate 3, I turn it on at 3,000 RPMs, and I titrate to a goal of around 5,000. Once you get to 4,000, you'll start getting flow estimates on your console. Don't forget the hematocrit. Things change in the OR, so you've got to make sure you're titrating the hematocrit on the pump. High hematocrit equals high blood viscosity and lower calculated flow, and I've seen this be off by half or 3/4 of a liter. The HVAD I turn on at about 1,400 RPMs, and I titrate to 2,000 RPMs. So the RPMs are a little different given the pump. Let's go to the next slide. So this is, I'm not an artist, but this is the extent of my art. Again, when I'm coming off pump, I'm looking at the septum. The septum is everything, and I'm going back to this mid-esophageal 4-chamber view often. What you have on the left here is the ideal situation. What you have on the right is really the not ideal or worst case scenario. If you have a dilated LV with the pump kind of free floating, that's good. You want to keep going, keep up titrating your RPMs. You'll then get to a point where you see the septum start to come in or flatten. So you're still okay there, but you got to start, you got to be cognizant at that point that you're going to cause a suction event if you continue to ramp it up. And then the earliest sign of a suction event is just that it's a very subtle bowing in of the LV septum into the LVAD pump very distally. And this is what I try and teach the people I'm teaching, or trainees or anesthesiologists I work with, that you're not going to see what you see on the right. It's not going to look like a crescent. It's going to be this subtle little notch going into the LV pump. That's the first sign that you're running into trouble. And so if I see that, I either slow down, give volume, or I turn the pump flows down. And then obviously if you see what you see on the right, your flows are going to be low, you're going to be hypotensive, you're going to have to turn the flows down. So so that's kind of what I'm looking at on the echo views. And if you're a perfusionist and you're interested, save this slide and see if you can kind of correlate that with what you're seeing in the OR.
Now, like you said, you give volume here. Could you continue giving volume on this far right?
Usually you can, but you got to turn the LVAD pump flows down. I think that's going to be the #1 fix. But you can give volume assuming the RV is okay. You can give a little volume, or leave some volume in if you're still on pump. But really, the ideal thing to do is just start over. Go back to 3,000 RPM, start over, and you'll see once you do that, the pump will separate from the LV apex, and it'll start to fill again. So we can go to the next slide. So RV failure in a lot of patients develops slowly, especially if you fail to diurese a patient, whether or not you're not diuresing well enough and then they develop failure because they fall off the Starling curve, or if they fall off the Starling curve and can't contract, and therefore you then lose flow to kidneys and can't diurese. It's like a chicken or the egg, what comes first? But I make an analogy to a slow-moving train rather than a crash and burn situation. It's really rare that you're crashing and burning onto an RVAD outside the OR, like in the ICU. And if someone's crashing and burning in the ICU, usually they're going to end up on ECMO. But usually the need for an RV presents itself as a slow-moving train, and you're talking about it in the morning, and things are moving along, and they're not diuresing, and things are just getting worse. And then all of a sudden, you're like, you know what, I'm just going to put an RVAD in them. And so you want to aggressively diurese these patients once their volume settles out in the ICU. And I know there are a lot of people against early CRT, but if it means getting someone back on the Starling curve, meaning relieving some of the stretch that the muscle fibers are seeing, then I'm all for CRT. And if it helps volume status and electrolyte status and kidney function, then go ahead and do it. Hypertension hurts LVAD flows regardless of an HeartMate 3 or an HVAD. My goal maps are 70s, 60s to 70s. If you're higher than that, you risk dropping your flows because of high afterload. If you see pulsatility from the art line, it means that there's more room for unloading by the LVAD. Inotropes can be weaned. You need more diuresis, but it's usually a sign of adequate RV function. Because if you think about it, if your RV is just gone to hell, you're really not going to be pulsatile. You're not going to be moving blood to the left side. And so, but if I see pulsatility, it means we're doing well. I mean, like, it's not something that's awesome to see, but it means that things are okay. And no one's really sure what the optimal aortic valve opening strategy is. So is it every beat should the aortic valve open, every other beat, every third beat, or should it not open at all? No one really knows. But I know that if the aortic valve is opening every beat, you're getting a pulse pressure, you have room to make changes, whether that's on the machine with RPMs or with more Lasix or diuresis or reducing your inotropes, all three of those things. So next slide. So these companies will put out HQ curves, and the HQ curves, H is pressure. H is the pressure difference between what you're seeing at the LV pump and the outflow graph, and the Q is flow. And you'll see for any given RPM, the HQ curve looks different, and you can kind of chart where you are for a given RPM on that HQ curve. And it kind of tells you how much work the heart is doing. And the reason I say afterload is so bad is because, you know, the higher the afterload, the higher the H in the HQ curve is, and the lower flows you're going to get or be able to generate. But the pump is not going to be able to generate huge flows if your blood pressure is 200 over 150 or something. So the way the HeartMate 3 uses this concept of HQ curve is they design this PI pulsatility index. And if it's increased, it usually means you got increased blood volume, better LV function, hypertension, less offloading. If the PI is decreased, it could mean decreased blood volume or RV failure. But you've got to correlate this with your flows. A PI event is not such a big deal, only in that it tells you that you could have problems down the line. And the pump is set to alarm when the PI differs from the average of a pulsatility index over the last couple cycles by 45%. And the pump speed is automatically reduced to prevent suction. A PI event is not a suction event, so those are not used interchangeably. A PI is a little bit of a warning, but a suction event is what happens if you ignore the PI events over long periods of time. So PI event just tells you that you could be running into problems, but it doesn't mean you're having. You'll have PI events a day, but no suction events. Or you could have like a couple PI events a day and a couple suction events. So it's the same thing. A suction event is when LV myocardium touches the LV pump, the LVAD, and causes a reduction in flow because of suction. So 1 to 2 times a day, you want to monitor the event analysis. You want to monitor the hematocrit, the low flow alarms, the settings, because you can change settings. You want to make sure the low flow on the LVAD are fitting with, so that if it does more than 200 RPM, and the RPMs, but not your alarms super low. RPMs can drop RPMs, but that's not picked up by the alarm. So you got to make sure your alarms are set okay. I usually start heparin on post-op day 1 without a bolus, and I shoot for a PTT goal of 40 to 60. You can also use 10A levels. I start warfarin the same day I start heparin. And for the HeartMate 3, I use 81 milligrams. For the heart HVAD, I use 325. I think that this is the HeartMate 3's way of throwing shade at the HVAD, because they'll say, the reps for the HeartMate 3 will say, oh yeah, well the HVAD needs 325 of aspirin. I think this is all just like, who knows? There's a tendency to have thrombus with an HVAD, but whether or not doing 325 of aspirin changes that, probably not, but that's just the way that, that company throws shade at the other company. Well, we only need 81 milligrams of aspirin. Okay, big deal. Anyway, next slide. So the HVAD's a little different because it gives you, it doesn't use a PI, it gives you the actual waveforms, which are interesting. And the waveforms are essentially the PI. They're the same thing. And they have this rule of 2. So you want your flows greater than 2 liters a minute, and you want your peak to trough difference greater than 2. So like if your flow is at 4 and it's going 4 to 6, toggling between 4 and 6, you're in good position. The same thing with the HeartMate 3 applies to the HVAD, except we use 325 milligrams of aspirin instead of 81. And you can learn a lot from HVAD waveform analysis. And this is kind of a this is for another lecture. I think there's a lot to learn. And if you look at the waveform will give you what the combination of PI and flow on the HeartMate 3 will give you. And then if we go to the next slide, you'll see, here we go. So this is important if you're dealing with these patients in the ICU and outpatient setting. The one ideal situation is higher flow and higher PI, or higher pulsatility. That usually means you've got too much volume or you have recovery, but your heart's functioning. So that's okay. The bad situation is low pulsatility and low flow. It means RV failure, hypovolemia, tamponade, occlusion, or VFib, VT. And then you have some other situations that kind of fall in between with higher flow, low pulsatility, or higher pulsatility, low flow. And I keep a little picture of this on my phone because it's not always evident, but this can really give you a quick differential if you're in a bind with someone who's got an LVAD in. We can go to the next slide. So the HVAD and the HeartMate 3 both have these cycles where they change their flow either every second or every couple minutes to lessen the degree of stasis. The HVAD has this what's called a Lavari cycle. So it's a 200 RPM decrease for 2 seconds and a 100 RPM increase for 1 second, and then a return to baseline, which occurs every minute. It washes the LV, it decreases blood stasis, and it minimizes thrombus formations. The HeartMate 3 has an arterial pulse, which is very similar, and it's a 2,000 RPM decrease every 2 seconds, and it can actually look like a pulse. So if you're looking at an art line tracing, you can be fooled into thinking that someone is pulsatile when they really aren't. We're currently doing a trial here of the Lavari cycle. We're randomizing patients to Lavari cycle versus no Lavari cycle, and determining whether that really makes any clinically significant outcome. So just know that both pumps have the ability to go up and go down. The HeartMate 3, you can't set it. It's constant. It's there. The HVAD has to be turned on. The Lavari cycle has to be turned on. We can go to the next slide. There are situations where you can decommission VADs, which means basically someone's recovered. And usually this happens in young patients with peripartum cardiomyopathy. It's younger people with reversible causes like viral or peripartum. The typical story is that they had an LVAD for a really bad LV failure, and then there was a pump malfunction, and the patient is still alive. And so they'll come in, and their pump's not working, but they're like sitting and talking to you, feeling well. You'll echo them. Their LV function is normal. So we admit them for a right heart cath and PA cath. We do an exercise test. We get them up, walk around the unit. We make sure they're wedged and their PA cath pressures don't rise. You want to make sure they're optimally supported. And there are two options. You can either go in there and surgically remove the entire pump. This avoids the risk of clot, avoids the need for anticoagulation, but requires a reduced sternotomy and a pump explant. Or you can plug the outflow graft endovascularly and cut the drive line. When you're doing this, you'll want to keep them on Coumadin at least initially, but we don't really have a good protocol, or we don't really know what the optimal length of Coumadin on these patients are, or the natural history of someone who's got a pump that's just sitting in their chest that doesn't work. So this is all kind of it's not that common, so we don't really know the long-term outcomes here. But those are the two options, and you can choose one of those two depending on institutional preference. Next slide. All right, so this lecture is essentially done. I do have some research that I've done. I did as a fellow with some people and patients in Colorado. We were putting these pressure volume loop catheters in patients who were getting LVADs, and we were putting them on the right side, just kind of taking a look at the RV contractility. And like you would imagine, RV failure was exposed with changes in loading condition, and like a slow-moving train, it didn't happen, instantaneously. So they were well decompressed, as evidenced by this yellow pressure volume loop in the bottom, kind of third to the right. And then in post-op day 1, their pressures were up, but their contractility wasn't great. So again, slow-moving train, not so acute. And the pressure volume loops on the right side demonstrated a decrease in preload recruitable stroke work and RV contractility, which means the RV did not have as much contractile reserve as we had thought after putting an LVAD in. And this goes for all patients, whether they're RV or dysfunctional RV. Go to the
next slide.
One more. Yeah, next slide. I think I have one. Anyway, there's not a reserve for the right patients getting LVADs. The number one cause of RV failure in these is LV failure, and this RV has been beat up long enough that there's not a lot of contractile reserve, so that when you put an LVAD in them, there's a 30 to 40% incidence of new RV failure or unmasked RV failure. So I think that's all I got. Go to the next slide, and I think there's nothing else there yet. So that's all I got. That was a lot. I'm sure it covered a lot of things, but I've even made myself fall asleep.
Yeah, that was very comprehensive and really good. I mean, that's a lot of exciting stuff. I mean, you guys do a lot of exciting stuff. We do have a lot of questions if you have a few moments. I know we're running short, but one of the big questions, which is a multiple people asking it, is where do you see TAH going, total artificial heart?
Yeah. I personally, I know that we've had patients discharge on a total artificial heart, but I don't know we're there yet. My preference is in someone who I think we're supporting to transplant, meaning bridge, if you want to use those words, would be either implantable BiVADs, so like let's say we do BiVADs with a CenterMag, or just ECMO, and central ECMO or peripheral ECMO where they can walk around, and a trach. I think all these patients need a durable airway, and in my mind, an endotracheal tube is a durable airway, but it's not going to allow them to get up and walk around. So I trach all patients who have central VA ECMO, or I call peripheral VA ECMO, with right IJ and axillary, like an axillary graft. That's enough flow for those patients to get up and walk around the unit. But I think anyone with advanced mechanical support should get a trach. A lot of them, if they don't get a trach, will lay in bed and plug. And once they get walking, I mean, once they're walking 3 or 4 laps a day and they're up and at it, even with ECMO, you can decannulate them. But those first few days or even week after you've reconfigured them to a central configuration, they're going to be laying in bed, they're going to be slumped over, their secretions are going to be going into their trachea. So I think for the first couple of weeks, everyone on mechanical support like that needs a trach. I'm not a huge fan of the total artificial heart. So again, my preference is central or peripheral VA ECMO, ambulatory with a trach. I don't know that I see the total artificial heart going anywhere other than what we really use it for now, which is we do it maybe once every 9 months. That's how rare it is. We're not big at total artificial heart center.
Mm-hmm. And why is that? I mean, so I mean, when you look at the technology, so your basically thought is that the total artificial heart, if it was, let's say, like the one that I think is being developed, you may know about it. I can't remember the name of it now, but it's a single device, dual chamber with some kind of a movable baffle in the middle that changes volume and so forth, where you basically implant it and forget it. It sounds easy, but we know it's really not. There's so many complications that are associated. So you think the direction in the short-term, near future is going to be an implantable, fully implantable BiVAD versus just a TAH?
It might be. And again, in my mind, our center is very comfortable with central VA ECMO cannulation and a trach. We ambulate people, we get them rehabbed, and we get them transplanted. We have a large transplant center, so we're able to transplant patients relatively expeditiously. If they're well supported on their current platform and they're ambulating, why take them back to the OR and subject them to a big operation?
Yeah, that's...
And they all bleed. I mean, constant bleeding. I mean, 3 weeks out, chest tube out, now they're reaccumulating blood where they didn't before. Mm-hmm. And it's not a function of surgical technique, it's just a function of, I mean, the total artificial heart is Tupperware inside someone's chest. And it just, the body doesn't like it. It causes all these coagulopathic derangements. And so it's just, I mean, it's an okay device, but in someone who's ambulating and on a durable, configuration with a trach, there's no reason to go back and so where do I see it going? I don't know. It might become a thing, just like cryptocurrency might, but really, I don't buy it right now. So.
Very good. No, that's really such a good point. So what are your thoughts on xenographs as far as increasing the number of transplantable organs for cardiac, for hearts?
Yeah, it's possible. I mean, we don't do any of that here, and we don't have really a research lab dedicated to that. Again, we're talking well into the future, and I'm dealing with what's in front of me, and and I know there are possibilities for a lot of different things in the future. But again, that's another technology I don't see ready for prime time. I do think that if we're discussing what is in the near future as far as heart failure goes, so we're now using the transmedics device to rehab hearts. I mean, I think there's a bigger possibility for either genetic or epigenetic manipulation in hearts that are kind of marginal, that are put on the box and let to sit, and then we can rehab them on the transmedics device. I think that's in the near future. I also think the NRP platform we discussed a few months back is also it's something that we're going to see in the near future. As far as years out, I can't really comment on it on a lot of the other stuff just because I don't know a lot about it. But I can tell you that our ability to rehab hearts using the devices we have today is more of a possibility than xenographs or anything else.
Interesting, very interesting. So you were talking about your when you do these cases on pump, but John, you can jump in anytime you'd like. Do you do your VAD implants with Angiomax or heparin? And obviously you're not using protamine, so do you just sit and wait for everything to wear off and get reasonable hemostasis before you close and get out of the operating room?
You're talking about protamine for LVADs?
Yes, you obviously aren't. You don't use so do you use heparin or Angiomax for your anticoagulation when you go on pump when you're going to implant an LVAD?
We use heparin. We use protamine too.
Oh, you do?
Especially the HeartMate 3. Yeah, we do. The HeartMate 3. I'm not really worried about that. I just bleeding is a big problem. Bleeding is a huge problem. So that's number one. Number one, you got to fix that problem, and then you can worry about everything else after. You gotta get some this is like something I made up. You got to get a little coating on that outflow graft. So, and you're not going to get that if you just leave them on, heparin.
And generally, we've got our flows high enough on the LVAD to avoid thrombus.
Yeah. Yeah.
So, are you guys doing much in the way of anticoagulant-free ECMO over there? Because we just recently started doing that and have had good results.
Yeah, we do. I mean, it's surgeon specific, and it's very not specific. I should say it's situational. We get some trauma patients who may need ECMO, and VV ECMO. I mean, that's easy enough. And I've run people on VA ECMO without anticoagulation before, and it's fine. I mean, I have a guy who was on central VA ECMO with a PA vent who had multiple codes. I reconfigured him to central VA ECMO, and I ran him without anticoagulation for about 12 hours until he was outside the window of bleeding, and then we slowly titrated it up. And that's central VA ECMO, so I'm not worried about that. I think that's something I worried about when I was a fellow because we didn't have a lot of experience with it. But I've had more experience with it now, and if there's a bleeding complication, I just shut off the heparin. I mean, it's just something you got to do.
Well, if they're coagulopathic, then really they're not going to clot anyway.
Right.
So you have to get all of that corrected. There's another question which I thought is a really good one. What is the optimal hematocrit for your LVADs? You were talking about hematocrit. What is optimal?
I don't know the answer to that, or if I don't. So I don't know if there's an answer that's been studied. But I aim for 8, 9, 10, somewhere around there. I don't really go chasing low hematocrit. So if they're 7, but they've been stably 7 for 5 days, fine. I mean, if they're 10, 11, 12, fine. I've not seen a patient who's much higher than that. I think after an operation like that, it's hard to have a hematocrit of I'm talking hemoglobin. I'm sorry. I'm used to using hemoglobin.
Yeah, okay, hemoglobin. Yeah, yeah, I knew
Yeah,
what you.
yeah.
We all knew what you meant. That's okay. We know you're
but
not running. We know you're not running your crits at your crits at 12. We know that.
yeah, their pump flows would be real high.
Real high.
But I usually am around. I usually settle out around 7 to 10. Is usually where. So.
How about on pump, John? What do you like to run on pump?
Usually we try around 30, between 25 and 30, preferably higher on the 30 end.
On your hematocrit, yeah. So your
Yes, sir.
so hemoglobin between 8 and 10, you're
And
fine with.
Yes.
What's your
Yes.
transfusion threshold?
21.
Yeah.
If we start getting around 21, 22, I'll discuss with him or anesthesia, and we'll kind of go from there. Depends on the volume status, we may pull some, but 21 to 22. And usually with our prime volume, if we don't rat, depending on the situation, we usually go on around 22 to 24.
Yeah. And that corresponds to a hemoglobin of 7.
Yeah.
And if they're 7 in the unit for multiple days, again, we'll let it ride. But if they're getting to 7 or less, usually even if they're not bleeding, or if they've been stable, I mean, usually we'll give them a unit. It helps their mixed venous, only because you're just raising one parameter of it, but it doesn't. I don't know that it does anything, especially if they're stable.
So anesthesia here always wants to come off 30. That's always their goal is 30.
Mm-hmm.
So,
I like that. I prefer a higher hemoglobin than lower, or crit versus lower.
Yeah.
For the O2. Do you aggressively ultrafiltrate when you're on pump?
If it's possible, I'll try to, because they're diuresing these patients already, so we'll want to get their volume intact. And if they're volume overloaded coming on with us, again, once they come off and get upstairs, he's wanting to get that volume down. So he said he's okay with the CRT. So if I can go ahead and pull some volume off while we're on pump, even better.
It's amazing the difference you'll see. The cardiologist will say, okay, this patient is volume optimized, and you'll get to the OR and they'll have no volume to give. And then you'll take someone else who's quote unquote volume optimized. You get to the OR and you take 4 or 5 liters off, and you're like, where did that come from?
Yeah.
So
well,
I like volume off. I'm always a fan.
Yeah, I think we historically grossly underestimate how much the patient is or is either tissue fluid overloaded, but not necessarily intravascularly from low COP or whatever the reason is. And I think we also underestimate tissue fluid basically being desiccated, and they have intravascular volume, but as soon as you go on pump and you drop your COP a little bit, there's fluid redistribution out to the tissues. And they can hold a lot of volume. There's a lot of volume out there that is either missing from where you want it or need it, or not being where you may also need it because it's going to leave you. So I think there's a lot of debate about that. But there's another question which I thought was a really good question, and I'd like to get your opinion about it. Obviously, physiologically, we are designed with a pulsatile arterial tree because the heart beats. But obviously at the capillary level, that is a little bit different. We do notice that it is more of a continuous flow in the microcirculatory area. Do you see anything with pulsatile pumps versus continuous flow pumps as far as patients' adaptation to their new physiology?
Not in the acute phase, no. I don't know if the incidence of stroke or renal failure or bleeding or AVMs, GI AVMs, can be attributable to a change in flow dynamics, but not in the acute setting. And a lot of times, again, you got to remember that in the acute setting, some of these people are still pulsatile. A lot of them are. I mean, a lot of people are pulsatile. So we say they're continuous flow pumps, but a lot of times these people are pulsatile. And the other thing is, with these washing cycles that the two pumps have, to a lesser VAD, but it can almost look like you're pulsatile on an arterial line tracing, even without pulsatility, just because of the RPM ramping up by 2,000 and down by 2,000. Whether that translates to real pulsatility in the body, I don't know. I mean, it certainly does on the art line. And so, and again, to answer the question, in the acute phase, we don't really see much of change in adaptation or change in or difference in patients.
Very good. Well, I mean, I've asked the questions at least that I got from our audience. John? Do you have any further comments you'd like to make to close this out? Any particular questions you may have for Dr. Hoffman?
No. Usually I catch him on the fly. It's when he's busiest. I have a question for him. Usually that's how it happens with him. But no, I'm good right now.
Okay, very good, Dr. Hoffman. Anything you'd like to close out with, and maybe you could give us a little bit of a preview of how you're going to go through this next. So the VADs Part 3, when we are able to schedule that, where are you going to go with this?
Well, I think the most important thing in my mind is that the best biventricular option for anyone is a transplant. And so we talked about LVADs and total artificial hearts and central VA ECMO or, BiVADs with centromags. But these are all just temporary and partial. Even in LVAD, it's still partial support. And so my goal with anyone is to get them to transplant. And we can do that at our center. I know there are other centers that can do that. But I think that it goes to a bigger discussion of heart transplant listing criteria and selection criteria and whatnot. But the best option is heart transplant, and if we can do that by any means, we'll do it rather than an LVAD.
Yeah.
As far as VADs Part 3, I'm going to have to come up with something.
Well, it may not have to be VADs Part 3. I think we could talk. I mean, there's so many different things, and I see your passion for transplant and how far superior you believe that to be over what is the direction of some industry going into the total artificial heart and essentially having what would be then an unlimited supply of mechanical circulatory support devices, whereas transplants has a limited number. You have to have the donors, and you have to have the ability to cross-match them and be a suitable organ for any one patient. So your real direction seems to be, at least in what I can extrapolate, is expanding the donor pool with these devices like the transmedics to get farther and farther away, and essentially reconditioning these organs to be able to be used. So that seems to be the direction you're going.
Yeah, I think it's exactly right. I mean, I think I love LVADs and I love all these mechanical devices and whatnot, but it'd be great to get to a point one day where we don't need them.
So ultimately, bridge to transplant is really what you view the VAD technology as being.
Correct.
That's the takeaway message, I think, for us. Listen,
Yeah.
I can't thank you enough. Again, this is yet another highly successful Vanderbilt Faculty Forum. It's been fantastic. Magic is back there giving me these 2 thumbs up. We appreciate you guys. I can't thank you enough. And go forth and conquer, and hopefully you'll have a good good organ to get today with your harvest, and another patient will be helped. It's of course it's tragically sad that we know that somebody had to have lost their life for someone else to live, but it's basically, if you look at it that way, it's tragic. But the other way, you basically are reducing the mortality by 50% by giving somebody that opportunity. Otherwise, both of them were not going to make it. So I think it's really something that is valuable in our society and our community, and we thank people like you so very much for being willing to take this very difficult task on with a great sacrifice of your own personal life to help others. So we appreciate that from both of you very much.
Maybe next time I'll talk about personal life sacrifice.
Could you say that again? Your signal was breaking up. What did you say?
I said maybe next time I'll bring my wife on and she can talk about the personal sacrifice.
I think that'd be fantastic. I think that would be fantastic. In fact, you bring up such a good point. This COVID has really, I think, the spouses of medical professionals have sacrificed during throughout our careers, and then also I think during things like we just experienced with the pandemic and us having to basically spend all of our time at work. So you're absolutely right. We get awards. We've given, of course, the Crystal Heart Award out, to people like Dr. Robichek and Dr. Ochsner and Dr. Cooley and Dr. Frazier and various different people who have done remarkable things throughout their careers, and incredible people certainly, but their families are really the heroes when you really think about it, because without that stability, they could have never done what they did.
Yeah.
And the same, I think, applies today. So you're right. Your wife deserves a vacation to Houston, so we're inviting her to the studio, and you can stay right there in Nashville.
Awesome.
Sounds good. Thanks, guys. You be safe. We'll see you next time.
Thank you.
Bye-bye.
See you later. Bye.
Okay. So can you want me to just move right on? Okay, do the opener, and I'll be ready to go. Hopefully, I'll do Tammy's Journal Club. I'll give it some justice. That was a really good program. How our numbers were good? Magic? Very good? Good. Okay, run the opener. Do it. And let me screen mirror. And hello, everyone. Welcome back. We're going to be doing Tammy Sparacino's Journal Club. I am your guest host, Joe Basha, and we're screen mirroring now. And joining me today is going to be my good friend, John Ingram, who does the Knowledge Nuggets, and thank God he's here to help me. Tammy has warned me that I better do a good job today. I've already told her that I'm not going to follow exactly her format that she normally does, but I'm a guest host, so I'm going to do the best that I can do. John, good morning. How are you?
Good morning, Joe. How's everything there in Houston?
It's great. Man, you're doing good. You look great. You working
Well,
today?
I'm running my tail off here. Just ran and did a case, got back just in time, so hopefully we can last this one out.
Absolutely. Okay, so I'm going to move right forward because I've got only, what do I have, 10 minutes? I have 10 minutes. I don't think I can do this in 10 minutes. You know what I'm going to do? Geez, I really don't think I can do this in 10 minutes, but it's a really good talk. I think it's better to schedule it for another time. I can't do it in 10 minutes. It's impossible. So
you want me to go to mine?
I think so, John. So, but let me just tell the audience, if I can, throw the slide up just for the sake of this. The Journal Club article is lower or higher oxygen targets for acute hypoxic respiratory failure, and this was published in January 2021 in the New England Journal of Medicine, and it's actually it really is a good bit of information. I want to go over all of it, and I want to do it justice, but I don't think I really can. But I will give you the takeaway message for those of you who may be interested in the bottom line. The bottom line, after all is said and done, is there was no difference in survival or mortality with a conservative versus a more liberal saturation or PO2 oxygenation strategy, whether it be at 60 millimeters of mercury being your lower and 90 millimeters of mercury or higher for your more liberal or a higher PO2 group. So your 90-day mortality essentially ended up being the same with either strategy. But I think there's some other nuances, and I want to, again, do this justice, and I don't think that I can in this short period of time. So if you guys want to get this article from New England Journal of Medicine, I'll reschedule this one, and I think we'll go right into Knowledge Nuggets. But I didn't want to interrupt Dr. Hoffman and John, because I tell you what, man, that's a lot. That was a lot of information. That was one very comprehensive lecture on VADs. And I personally, we had a bunch of questions. I almost said something else. We had a lot of questions from people on that, and a lot of people watching it. And I think that I personally learned a tremendous amount from listening to that lecture, and so I was very impressed with it. So, John, listen, the audience, please forgive me. I'm going to skip the Journal Club and go right into the knowledge nuggets. We didn't run his intro, but I think that's okay. I think everybody has seen it. We can run it at the end. We're going to jump right into John Ingram's knowledge nuggets, and John, you can tell your story.
All right. Good evening, good day, I guess, to everybody who's listening.
It's good morning, John. It's the morning.
Good morning. Joe, our days and nights are all backwards these days with the craziness, believe me. So I guess we have the slides up, I guess.
Yep, he's getting them up now. So I'm throwing David curveballs. He always loves when I do this to him.
Yeah, I bet.
He loves it. But I didn't want to interrupt Dr. Hoffman. I mean, I didn't want to interrupt him. That was just too incredibly good a lecture for me to want to say anything to him. I just let him keep going. And that's one smart guy.
Yeah, guaranteed. Well, this is episode number 9, Joe. I guess we're at June 2nd, 2021. You believe that? And John Ingram Knowledge Nuggets. Of course, on this one, as all of them, I have no disclosures. So anybody who hasn't seen the show before, our motto is, on the Knowledge Nuggets program, spend a little time and expand your mind. So this week's topic is going to be atrial septal defects, something we've known a lot about, but haven't talked about in a while. So every week is a different topic. I hope to give you something you can take home with you. You can screenshot and take it with you. Tomorrow be a better clinician. When you see a gold nugget in the upper right corner of the screen, you'll know that's a take-home slide.
Dude, I look for those nuggets all the time.
Yeah, there you go. So
in fact, I'm gonna create the John Ingram Knowledge Nugget Award.
Yeah.
Limited editions. I'm gonna have to sign them.
Yeah, and so what we try to do is, you try to think back on a lecture that you heard, but what can I really tell my friend about it? You can screenshot and say, look, this is something that was important that I learned about this topic. So we try to keep it short and sweet, 12 minutes or so. At the end, we have a couple-minute gem of the week surprise. You never know what that's going to be. Something interesting, could be anything. Then we have a panel discussion, and if you guys want to reach out to me after this one, or if you're watching this in the future, you want comments, questions, email me at john.ingram@perfweb.us. And as always, I respond to every person who sends me an email at that address. What is atrial septal defects? You're going to see it called ASD. We all know that we call it ASD. So what is it, definition of an ASD? Well, an ASD is a congenital heart defect in which blood flows between the two atria of the heart. And this accounts for 6 to 10% of all congenital heart defects. It's relatively common. ASDs typically result in a left to right shunt from the left atrium over to the right atrium. So you're going to result in right atrial enlargement, RV dilatation, and on occasion, it can even result in left atrial enlargement. And it's correlated according to the QP to QS ratio. What does that mean? The flow of the pulmonary circulation versus the flow of the systemic circulation. And normally, that is 1-to-1, right? But when that becomes too lopsided and you have too much flow going into the pulmonary side because of this shunt, that's when it becomes a problem, and we should address it and perhaps correct it. There's multiple types of ASDs. Ostium secundum defects, ostium primum, sinus venosus, coronary sinus defects, and also you can have a combination of these. They don't necessarily have to occur on an isolated basis.
I don't know. Do you have anything in here? Do you before I say this, and forgive me for interrupting you. Do you have anything in here about Dr. Gibbon?
No.
Okay.
Well, I allude to it in the end there. I'll show you something, because you're absolutely right, Joe. I have one history slide.
Okay, I won't say anything then. I won't say anything, because it's so appropriate to this lecture.
Open heart surgery and perfusion and the whole history of where we are today owes itself to this defect and the efforts that went into correcting this defect. You're absolutely right. So here's an overall, simple view of the chambers of the heart, and you see that the oxygenated left atrial blood is shunting over to the right atrium. So you have a left to right shunt is what's happening in these atrial septal defects. So let's look at the different types. Ostium secundum. This is the most common type of ASD, and it basically arises from an enlarged foramen ovale and an inadequate growth of the septum itself, the septum secundum. So an ostium secundum ASD, if it's in combination with a mitral valve stenosis, it's called Ludenbacher syndrome. Some people may have heard of that. So I'm going to show you a slide here to show you the several types of ASDs, but circled in red there, the one I'm talking about at the moment, the ostium secundum atrial septal defect, basically right in the middle, pretty large most of the time, middle of the atrial wall, and of course you're going to have a pretty large shunt usually coming across from left atrium to right atrium. So on the ostium secundum defect, most do not have significant symptoms through early childhood, believe it or not, but 70% will develop symptoms by age 40. The symptoms that one would notice are decreased exercise tolerance, easy fatigability, palpitations, and syncope. Complications of uncorrected secundum ASD include pulmonary hypertension and right-sided congestive heart failure. Progression to Eisenmenger syndrome occurs in 5 to 10% of individuals who go uncorrected into the late disease process. And as you know, Joe, Eisenmenger syndrome is really something you want to avoid because it becomes a chronic and irreversible pulmonary hypertension that can develop when this is left uncorrected for a lengthy period of time.
And then you can actually reverse your shunt and go from left to right
Correct.
to right to left because of this increased pulmonary circulation and resultant pulmonary hypertension.
And then you know you have a real problem, which is why I said earlier they look at that P to QS ratio for the shunt ratio, and also it did mention that you could have left atrial dilatation in cases of ASD, and I think that's what they were trying to refer to, is that when you get to this end stage and the shunt goes the other way, you can actually have left atrial issues.
Yeah, you're
So
in
now
trouble.
we're
You're in
looking at
trouble. You're in trouble when
you're in trouble.
with shunt reversal. You're done.
You're done, correct. So the second type, ostium primum, it's less common, of course, than the ostium secundum defect, but most commonly, the ostium primum defect, most commonly, it's the atrial aspect of an atrioventricular canal or an atrioventricular septal defect. Normally, it's not that common that it occurs on its own in an isolated case. It can occur that way, but most commonly, an ostium primum ASD is the atrial aspect of an AV canal, which is an ASD and a VSD. So it's classified as an ASD, of course, if the defect is an isolated ostium primum defect. But this is commonly associated, in about 20% of cases, commonly associated with Down syndrome.
Interesting.
So again, here I'm showing you that it's basically in this location, and it gets very close to the mitral valve here. I'm sorry, the tricuspid valve here, very close.
I think is that the tricuspid or the mitral? That looked like the mitral.
Well, yeah, I guess it is with the that's what I was trying to understand this drawing.
Yeah,
So
I think you're looking at the left atrium.
Yeah, you're looking at the right atrium, are you not?
You look at the right atrium? I don't know.
Yeah,
that looks like the mitral valve to me, but maybe.
It does, yeah. But you're looking at the right atrium, but the IVC and the SVC there, so a little confusing what they're trying to point out there, on that drawing.
Glad we don't do surgery, John. We run that pump. Yeah, yeah.
So you can, in the sinus venosus ASD, it usually involves either the SVC or the IVC. And a sinus venosus ASD that involves the superior vena cava is generally located at the junction of the SVC and the right atrium. The IVC version is a little bit higher than the junction, and it basically occurs in the right atrium, but the SVC one is right at that junction. And for some reason, it's frequently associated with an anomalous drainage of the two right-sided pulmonary veins will end up draining into the right atrium instead of the left atrium. So it's a common second anomaly that occurs there with this one. All of this is occurring in embryology, right? So you have many things that that can go wrong in the embryological development. And you see there how the inferior sinus venosus defect is just inside the atrium, whereas the superior vena cava one is at that SVC right atrial junction. So you can also have a common or single atrium, and this is basically a failure of the development of the embryological components that contribute to the atrial septal development itself. So you have this wide open, basically almost an absence of the atrial septal wall there. And a lot of times this can be frequently associated with heterotaxy syndrome, which is a reversal of the organs from left to right within your thorax. So you see here on an echo, you see the atrium there at the top. There's no atrial wall at all. You have wide open communication between the left and right atrium. So now you can have a mix of these, and of course that runs the gamut. But mixed defects account for only 7% of all your atrial septal defects. The normal intraatrium septum can be anatomically divided into basically 5 septal zones, and any defect involving 2 or more of these septal zones would be termed as a mixed ASD defect. So here's your history slide, Joe. And since the early reports of surgical atrial septal defect closure in 1948, which was attempted originally without direct visualization, and again in 1952 with hypothermia and inflow occlusion, we have over 50 years of surgical experience that's resulted in an operation now with minimal mortality or morbidity. And I didn't isolate Dr. Gibbons and the early heroes in this, but perfusion and open heart surgery owes a whole lot to the ASD defect, which was tempting enough for the surgeons to attempt.
Yeah, well, it was the first.
Early on.
It was actually the first successful use of cardiopulmonary bypass was done by Dr. Gibbon at Thomas Jefferson University. I think the lady's name was I can't remember her name. Bloviak, I think. I can't remember. And she was an 18-year-old ASD repair. First successful use of cardiopulmonary bypass.
Right. It's exactly why I wanted to throw in a little bit of a history slide there without getting too involved with that, because that is a fascinating thing, though. So for people watching, the ASD, the atrial septal defect an anomaly, we kind of owe a good amount of history to this defect, because it's where it really all started, and where the operations were attempted. So, but of course, ASDs are closed via median sternotomy and cardiopulmonary bypass, but there have been evolving minimally invasive approaches have emerged, and in fact, pretty successfully. You have video-assisted thoracoscopy and robotic surgery are now pretty safe, and they have improved cosmetic results, shortened recovery times. And for isolated secundum defects, surgery can be performed now with a near zero mortality. You also have, there can be some major morbidities. They include arrhythmias, pneumothorax, bleeding, pericardial effusions, pleural effusions, but these are usually transient and pretty rare. The long-term results of surgical repair are excellent, especially when patients are operated on under 25 years of age with a survival curve identical to the general population, meaning their life expectancy is not decreased at all. It's exactly the same as someone who did not have this defect and did not have to go under the surgery. There's no decrease in life expectancy. So as you can see, the surgical operation would be a patch repair or closure under direct visualization. Go ahead, guys. Yeah, and then if you're going to do a minimally invasive, you go on fem-fem bypass, and you'll do a minimally invasive incision there on the upper left, on the upper right. So this is a right vertical axillary thoracotomy approach. It would look something like this, is where your incision would be. And then if you're going to do a VATS procedure, you could have your incisions located there for the scopes and also for the third intercostal space, axillary thoracotomy approach there as well. And so kind of would look like this. You'd have the fem-fem bypass there, and then the VATS procedure going on. So just to give you some idea. So also, though, if the ASD is not too large, we have other options. If it's not too large and there's a sufficient firm rim around it, a closure device may be introduced into the heart via the cath lab, via a catheter. The catheter enters from the groin, goes across the ASD, and then it deploys the device. I think I have a picture here. It's kind of an interesting looking device, Joe. I wouldn't have imagined it looking quite like this, but this is the Implantation septal occluder, and it's a device specifically designed to close an ASD.
You know, there's a whole practice that exists. I don't know if it still exists, but it existed for a period of time, where these devices are made of nickel, and people that had nickel allergy were having problems with them, and they were going in and removing them and closing the ASD, doing a primary closure of the ASD or a patch, pericardial patch, or whatever it is. And so, yeah, real interesting. And I got involved in a case that this was the original procedure, was the removal of this, and I found out through that there's been practices that have been built on removing these devices, interestingly enough.
Oh, really? A whole industry evolved over replacing the nickel devices.
Yes.
Huh? Interesting. I didn't know that.
That should be a nugget.
All right, so we're up to the gem of the week. Yeah, that should be gem of the week. And as you know, this can be anything, could come at you from any angle. Could be a trivia question, could be something about how to tips on how to be a better interviewee on a virtual interview or in person.
You know, we've hired 4 people.
Yeah, there you go. Awesome, Joe.
I think it came from this.
Could be a job post. There you go. Could be something I could throw at you, a new product recall or something in perfusion news. Could be something that we just had perfusion week, and I'm going to look into that and see if I can find something maybe for next time interesting that occurred. And remember one time, Joe, we did a famous quote, and we talked all about the implications of a famous quote. It actually was by Einstein. Or I could talk about an upcoming meeting like the great New Orleans conference that you have every year there,
We're
Joe.
bringing it back. We're bringing it back.
Right.
We are bringing it back.
This week's episode, Joe, you're going to love it. It's called The Case of the Teenager Who Swallowed a Sewing Needle.
Can I tell you something before you tell me this? Because I want to hear this. I actually know someone whose kid swallowed a bunch of those little magnets. They were putting them on their braces and then ended up swallowing them and ended up needing surgery to have them removed.
Well, check this little scenario out. This happened in Massachusetts, and it was last year, published in the Journal of Emergency Medicine, July 29, 2020. Dr. Bonnie Matthews at University of Mass Memorial Medical Center in Worcester, Massachusetts, had a case of a teenager, came into the emergency room. A teen swallowed a small sewing pin while tailoring clothes. He didn't even notice that he had ever swallowed a pin. So it was a surprise to everyone when some days later, doctors found it in a very unusual place in his heart.
What?
Yeah, check this out. A 17-year-old went to the emergency room experiencing chest pain. The teen said the pain was sharp, radiated to his back, and was worse when lying down or breathing deeply. A CT scan of his chest showed a linear metallic foreign object lodged in his heart. The object was 3.5 centimeters long and was lodged in the right ventricle. And I think I have the CT scan here. You see that? There is the sewing pin in his right ventricle. The CT scan of this teen. Go ahead, next slide. So the teen initially told the doctors he hadn't ingested any foreign objects. In a later interview, he revealed that he tailors clothes occasionally and holds sewing pins in his mouth. Still, he was not aware of ever ingesting a sewing pin. Open heart surgery revealed, however, it was indeed a sewing pin. And there you go, Joe. Now, how does a sewing pin that you swallow end up somehow into your venous system and end up lodging into your right ventricle. What is the pathway by which that could occur? Very
Okay.
interesting.
Okay. So, let me think about this for just a minute.
This is speculative. I'm not quizzing you. I don't know either. We can only speculate. I don't think
You mean
anyone's
you don't know
tried to-
the answer?
No.
How do
Nobody
you?
knows
Where
how
was
this
this at?
University of Massachusetts.
I mean, Worcester. That's right. I mean, have you not called her up to? Does she know? Does anybody know?
I don't. I think. Well, this is my take on it. This is my after talking to a few people. You ingest a sewing needle, so this is in your GI tract, right? And the end result of this is going to be that it passes through to the end 9 times out of 10, unless it gets and hung up somewhere. Somewhere along the line, it seems to me, and it seems to some people that I spoke to, that it got into the mesenteric area of the GI tract where peristalsis is going on pretty heavily. This pin may have become sideways, and as peristalsis was trying to move it forward, it actually pierced it into the arterioles and the capillary there, and somehow went perfectly into a venule and was able to go upstream and end up into the venous system. How is this possible?
I don't think it did that.
Unless
I mean,
he has some strange anatomical shunt somewhere, in his esophagus or something that, is undiagnosed. I can't imagine how this managed its way into the venous system from your GI tract. I really can't imagine how this happened.
unless it got stuck in his esophagus, and I would think that it. I mean, the only thing I could think of is it got in the esophagus, because when they do a TEE, they go into the esophagus and it runs right behind your heart, and that's why you can get those views, and migrated from out of the esophagus into the ventricle, like right there directly, because I mean they're right next. It's literally right next to it.
Actually, now that you say that, the article said that the pin was jutting out of the right ventricle, jutting out of.
Yeah,
That's actually how it was termed.
So I don't think it ever got in the heart. I think it migrated out of the esophagus and into the RV. That's my hypothesis. I'm going to look this up and call this lady up.
If you think about the esophagus is posterior and the right ventricle is very anterior, right? The way the heart sits in the chest, when you
Well,
open up
it does, but some of it's wrapped around.
Yeah.
It's
Back by the septum.
yeah. I mean, I think it could. I mean, unless it just got it. I mean, I don't know. I mean, that's my best. That's my best hypothesis.
This is the first case in the article they wrote that they know of that someone had a foreign object lodged into their heart that wasn't physically, impaled or stabbed or something along those lines. To have it go from ingesting it into your heart, I don't think they have a not documented case other than this one.
Now, I guess there's the option that, I mean, I've seen people do some crazy things unless he went to sleep and it actually pierced into him, because it's a sewing pin. So, I mean, I don't know how big that is, but pierced him. That piercing, like a little IM injection or something, healed over, and it migrated through his skin, then into his RV, and it just eventually just sort of made its way all the way through. I don't know. I would have thought that they would have taken an awful lot of pictures when they opened this kid's chest up. How did they get it out? surgically? I mean, they do a
Yeah,
sternotomy?
they did open heart surgery and removed it, and it was a sewing pin, and he recognized it as, the sewing pins that he typically uses. You know, I don't, we could probably look into this further, see where on the right ventricle, in the right ventricle, it was lodged. It would be
Dude,
interesting.
this is supposed to be the gem of the week, and all you're doing is teasing everybody with it. I mean, that's
Exactly.
not even like, really. Now you're going to force me. It's your job. This is your job to reveal this.
I have the CT. You can judge for yourself. There's a CT right there.
Well, I'm going to call this physician up. I'm going to call her. I'm going to call her, and I'm going to say, okay, now so next time we're together, I'm going to actually have the answer to this because I now need to know the answer to this.
Okay, yeah, that'd be great. Let's make it a part 2 gem of the week, part 2 for next time.
You know, I probably should have gone ahead and done the journal club because actually now we're early. But you guys over there aren't telling me what I need to do.
Well, if you have enough time, you could do it.
I'm sorry, what'd you say? I'm not following the schedule. Okay, so we're gonna do. I'm gonna do this journal club. I think on the 17th, because right now I've got a perf web scheduled for the 17th, and it's actually predicting VA ECMO survival with SAVE. So what I'm going to do is I'm going to take 40 minutes of that time and do this higher versus lower or liberal versus conservative oxygen levels for ECMO, and do it then and add it to this. So we'll do it that way because I think that everybody I think everybody's had enough. Your knowledge nuggets was great about atrial septal defect. I appreciate it. It was very, very concise. It was great. But your gem of the week was the worst gem of the week you've ever done. It was most fascinating, but the worst you've ever done because you're not telling us enough. And we're going to find that information out. We're going to do it the next time.
Well, I can tell you something that I did leave off the ASD lecture, and that is about PFOs, right?
Yeah.
Patent foraminal valve, which 25% of all adults, patent foraminal valve exists because it never actually grows and adheres to the atrial septal wall. Now, you don't have a shunt, but occasionally the 25% of us that don't have the foraminal valve that's grown solid to the atrial wall, even when we cough every now and then, we could have a quick burst of an atrial shunt that goes on. But I can tell you, we see this in ECMO, Joe. Maybe you do as well. Have you ever had a VA ECMO where you had the femoral venous cannula all the way up into the right atrium and you're on a high flow and you're straight VA ECMO and you have an SpO2 of 95 or even 99 in your venous line, and nobody can understand because you're difficult oxygenating the patient, how do you have a 99+% venous saturation? And this is because we're causing such a tremendous suction and negative on the right atrium that we've caused the patent foraminal valve to open and get a shunt across there, correct?
Yes, I've seen that happen. I've also seen people put transeptal left atrial vents in that same situation on VA ECMO, and the blood coming out of the left atrial vent is dark, and they're like, they didn't understand why, and the reason was we were pulling it from across the opposite, from the right to the left. The patient's lungs were working. That wasn't the issue. The issue was that the left atrium was so decompressed and they had a small ASD, and there was a right to left pull because the left atrial sump was pulling so hard. So I've seen that happen too.
Wow, that's interesting. So you're getting dark blood out of the left atrium because you're pulling it across from the right, and in these occasions of ECMO, we have bright red venous blood that we're pulling across from the left atrium.
So I've seen both of those happen actually. So I've seen that same occurrence occur with VA ECMO. So, well, thank you. Okay, John, close us out. Should we do the wheel? I don't think we should.
You know, I love it when somebody lands on dissecting aortic aneurysm or extra call. I think that's so much, so fun.
I can't do it without Tammy here, though. So we're not gonna do it. We're gonna just tell you everybody that our next program is gonna be on June 17th. That is a Thursday. It will be at 14:45 hours or 1500 to 1700, and it will be on the liberal versus conservative oxygenation strategy for ECMO. And so I'm going to have Tammy do it because I've already got her slides for her, although it's not in the same order. And I'm going to be doing the predicting VA ECMO survival with the SAVE score. So we will see everyone on the 17th. Sorry for ending early. We'll make up for it in the next one. That happens sometimes. John, my good friend, thank you so much for continuing to support our program. How's life going out there for you guys? I haven't talked to you in a while.
Oh, great. The masks are all but vanished. I was down in Key West last weekend, and there was 0 mask wearing requirement anywhere in Key West. All the restaurants and bars are like normal. People are up and down the sidewalk like normal. It's almost like a different world. And I hear that the new cases of COVID nationwide are at an all-time low. I heard on the news this morning. So hopefully we're over a hump, Joe. Let's pray it continues, right?
I certainly hope so. We have one patient left at this point in time that's COVID, and it's a tragic case. I hope she can turn the corner, but right now it's not looking too positive, and it's very sad. It's a very tragic situation. But how about in the hospital? Are you still mask mandated throughout the hospital?
Well, they stopped screening people as you walk in. There's nobody now doing the temperature and the mask thing. It's sort of just sitting out there for a mask if you want to take one. They have them out. Everybody, I think, is so addicted to wearing the mask in the hospital that I think I haven't seen anybody walking around without it. And I'm trying to lead the way a little bit on that. But it's such become ingrained into what you do that you're almost afraid not to, right?
Yeah, it's very interesting how this has all affected all of our psychology.
Mm-hmm.
So, now I walk out of my car and I go and I stop and I go, oh, I forgot my mask. And I actually go back and get it. And then I walk into the business and there's nobody there wearing a mask except me.
Mm-hmm.
So it's happening, it happens. And I'm like that because at work, one of the hospitals where we work had a regulation that said if you are caught in the hospital without a mask, your first offense, you're suspended for 30 days. Second offense, 90 days. Third offense, termination.
Wow.
So they were very serious about it.
I haven't heard anything like that. But I tell you what happened to me a week or so ago. I was in a department store, and there was one customer, man, walking around, no mask and everything, and it was totally okay. And nobody working there was saying anything to him. Went up, paid for his products and stuff. And I said, you know what? I'm taking this off, and I'm going to start trying to wean myself back to normalcy. You have to force yourself to walk around as long as it's okay. It's permitted that you don't have to. I'm seeing signs on doors that have been coming down now, and I'm seeing signs on doors that say mask encouraged, no longer mask required. So I'm trying to do it, take it down where I can try to teach myself what it was like to not have to walk around every minute with this mask on. You don't have to reverse this addiction you have.
Well, and then, of course, the question is, did it really help? Did it matter? Did the mask really stop the spread? That's still a very debatable topic. So who knows what the answer is, and who knows if we'll ever actually know. What? You need me to stop talking?
How about it? Yes.
Oh, why? Oh, we'll get cut off. I forgot. We'll get shadow banned. All right. But you should wear masks. Everybody wear masks. Where's my mask? I need my mask on here. Wait, here. I've done this before too, walking through the hospital. And that's been the way I did it. All right. Well, John, thank you once again. Everyone, our viewing audience, thank you. Be safe, and we'll see you on June 17th. Thank you all very much. Good afternoon.
Have a good day.